Ready? Nearly ready. Okay. Good morning, everybody. Good morning. Good morning. Good morning. And welcome to the Integrated Care Board meeting for the 24th of January, 2023. And also welcome to this super venue. It's lovely, isn't it? And been in the cathedral complex and a nice room as well. So thanks to colleagues for sourcing this, and thanks to the Cathedral and the Dean for offering it. Most helpful. So as you know, we're live streaming. So we do have, welcome to board members, of course. Welcome to members of the public, and welcome to colleagues on the live stream. First of all, notification of any questions from members of the public. Joe, do we have anything? Nothing received prior. Okay, thank you very much. There may be some questions that come in during, of course. In terms of introductions, I think I'm right in saying we all know each other. There's no new member around the table today, is there? For the first time in our setup period. So I don't think we'll take the time to go round the table. We've got two colleagues on listening to the stream, watching the streaming, hopefully, being Andrew Reid and Steve Clark, who have both unfortunately had to give apologies for today. But with that, why don't we go to Joe for the apologies? So over to you, Joe.
So apologies have been received from Steve Clark, Stuart Richardson, Paul Jabara, Councillor.
Hang on, Joe. You might just need to put your microphone on there and.
So apologies have been received from Steve Clark, Stuart Richardson, Paul Jabara, Councillor Reid, Sam Glover, and Andy Yaku.
Okay, thanks very much. And then declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item today, other than those of which we're already aware, of course? No conflicts of interest. Wonderful. Thank you very much. In which case, let's go on to the minutes of the last meeting, 22nd of November, 2022. All of a sudden, it seems a long time ago, doesn't it, last year? Could we turn the pages? I think we'd better, because I know of one typo that we need to correct. So rather than taking them on block, let's turn the pages this time. There are 15. This is for accuracy first, please. Page 1, 2, 3, 4, 5, and 6. And I have 13. Mine is on 6, 7, 8, 9, 10, 11, 12, 13. I'll come back to the one that is on 13, 14, and 15. So the one typo which actually Steve Feast spotted and kindly notified Joe and I about is in 22069 on page 13, where it accidentally says that the executive will deliver the strategy, and it should say the executive have a role to execute, not set the strategy as set out by the board. Steve suggests is adding in the board and NHSE. So that sentence should read, the exec have a role to execute the strategy as set out by the board and NHSE. Is everybody content with that amendment? Done. So with that one amendment, are the board happy that the draft minutes as presented are a true and accurate record? Agreed. Excellent. Thank you very much. Let's then go to matters arising from the 22nd. There are, you've got a paper there which indicates whether they're the state of completeness or whatever. I think the first one, 23060, is in progress. But Andrew, do you have an update on that for us?
Yeah, that's correct. That's nothing more than is in the action log, meeting at the end of the month to take it further.
So shall we leave that in the action log for the time being? Good. And then the next one, 66, which is Amanda, I think is complete. Nothing to add, Amanda? No. And the second one, let me just get this right, 069, also complete, Amanda?
Correct. Yeah.
Okay. And then there are three, oh, sorry, Sue, I beg your pardon. Oh, no.
There was an action for Patrick and I, which we've taken forward.
Right.
66.2.
66.2. Oh, yes. Yeah. Sorry, missed that.
Which take forward and we will send something back to
Okay.
the board for suggested inclusions in the risk register.
Oh, thank you for that. So shall we leave that on for the time being and not finished yet? Work in progress. Okay. Thanks for spotting that, Sue. Missed that. My apologies. 69, Amanda, you said was complete. And then 76, which is 3 questions from the public. The first one around national contracts, Ed.
So that's complete in the sense I've liaised with NHS England. What I haven't had is a response. So it could be incomplete from that perspective.
So again, should we leave it in as a to be completed? And then question 3, item number 2, but question 3, training and autistic for autistic adults. Lisa?
Yeah, I think I responded to that question in the meeting around just to update that there is the Oliver McGowan training, which will cover people with learning disabilities and autism. I will make sure I share the links. We've got some websites which will support social prescribers. I'll share them.
Okay, so should we take that as complete with the link shared? Everybody happy? Thank you. And then the final one, question 4, item number 3. It says complete there. Maddie, anything to add?
We have met, and as you'll see in my report, there's going to be some focused work on Felixstowe for the Alliance in the next quarter.
So should we take that as complete and we can take it off? Yeah. Okay. Any comments on the action log as presented and the actions? Everybody happy that that's a fair representation in the action log and with those updates? And with regard to the meeting of the 22nd of November 2022, is everybody content that the action log appropriately captures the actions it should have done, or is there anything that you think it missed and should be added? Action log complete, true and accurate record, all agreed? Thank you very much. Okay, in which case, let's go on to item 6, which is the general update from Ed. Over to you, Ed.
Thank you, Chair, and good morning, everyone. I wanted to start by paying tribute to Dame Claire Marks, who's, I would suggest, has been our finest leader in this system. Claire sadly passed away due to pancreatic cancer in November, which is a huge loss to us locally and indeed nationally. She's someone who broke glass ceilings in terms of leadership from women. She was the first female president of the Royal College of Surgeons and the first female chair of the General Medical Council. Last week, Nick hosted a remembrance service at Ipswich Hospital, where Claire had worked for the last 30 years, and there's a fantastic kind of order of service that was shared with everyone that was there. But one thing that was brought to our attention is that when Claire stepped down from the GMC, she wrote a letter to all of the doctors in the country, and I just wanted to kind of read from it. So I think it's very profound. So she said, "There is so much to admire in the health service's response the last 18 months, referring to the pandemic. But perhaps the greatest triumph is not what has been done, but how it has been done through camaraderie, communication and collaboration. My wish is that this spirit carries through to the months and years ahead, so that every doctor and every patient experiences the compassion that defines first-class care," which I think is really profound. I was thinking a lot about that in recent weeks, given the huge challenges that we've faced locally in terms of the demand for particularly urgent emergency care that we've seen roll forward in our system. We've seen real concerns around strep A during December, and we saw a peak of COVID and flu reaching its peak on New Year's Eve. This subsequently fallen. In addition to that, we've had obviously industrial action from the nurses and the paramedics, and prospects of further action in the future. So I think it's never been more important to consider Claire's words around camaraderie, communication and collaboration to work through some of these issues. I'm very pleased to say that I think our response to the industrial action as a system was magnificent, really well planned and executed. And there was a real sense of camaraderie and collaboration in the way we responded. And I think we've seen improvements in urgent and emergency care since the new year, which we need to sustain through that approach. Supporting all of this, if I can stay on urgent emergency care, is national funding that has been brought forward to support discharge with an additional £200 million that's been made available nationally and for us locally. We're seeing innovations start to grow around particularly use of digital with virtual wards. And we talked about care tech at this board meeting last time, and really pleased to see the Cassius Plus work starting to develop in West Suffolk now. That I think will have great benefits for the whole system in the future. And we can talk a little bit later about how Andrew would help us talk about how we're working with ESIS to look at our response to the system. But I think the moment now is for some very big ideas, and we had an executive session yesterday talking through some of the ideas we might consider to bring into the on the back of the ICP strategy we'll hear about, but also the joint forward plan, and also to use some of the national opportunities that we have. So Will and I met with one of the health ministers. We now meet with ministers regularly as part of our role in the ICB, and they're very keen to support the work we're doing around dentistry, and we'll hear more about that today. Nick and Dr. Neil Macy was invited to meet the Prime Minister in December to talk about the recovery and reset of the health service. And so that's an opportunity for us to influence national policy, particularly around elective care regarding Nick, and primary care with Neil Macy. And last week I met with Chris Whitty, who's very interested in the work we're doing in Clacton and wants to support how Clacton could be an example for other coastal communities nationally in terms of tackling health inequalities. So we have some very good opportunities to land big ideas and influence locally and nationally. In terms of other things, just a few other things I wanted to highlight. Firstly, congratulations to Nick Rayner. So Nick is the chair of Suffolk Primary Care, which has brought together 9 practices, I think with a population coverage of 120,000. It's a fairly new arrangement, but the CQC have visited and rated them good with outstanding for leadership, which is fantastic and shows another kind of model that we might pursue and build on for the future in terms of building, improving quality and building resilience in primary care. We have, on the back of an idea from Nick, actually from Gloucestershire, we've, through Amanda's office, we've set up recruitment fairs for care support workers, which have been very successful. They've been held at Colchester Football Club and venues in Suffolk too. I think we've made offers to 179 individuals on the back of those fairs. So I think that's a brilliant thing. We can do more of that going forward. And then finally, we've opened in Suffolk 2 STEAM cafes run by Access, which is supporting people in mental health crisis and providing more of a system and community response to that situation, which we're really very, very excited about. That's been long in the planning. So that's a range of introductions. Chair, happy to take any questions and then move into the agenda.
Thanks, Ed. And appreciate that and update, and indeed all the work and engagement from the teams, as I'm sure the board does. Could I just ask a quick question, Ed, before we go to see if there are any questions from colleagues? How is it in general? How is morale holding up under all the pressures that system members are under at the moment?
Well, it's a question I can give a view, and I think others around the table will be also well placed, from whether it's primary care, secondary care, community, social care. Mm-hmm. I think morale is a challenge, isn't it? Mm-hmm. I think there's no doubt that there's people who are working incredibly hard under a lot of pressure. There is some unrest in terms of people's pay and reflected in industrial action. But I think that's balanced against the incredible collaboration that we've seen, the new ideas that are emerging, and I think there's a bit of a sense of optimism going into this year that we can move forward. So I would give a balanced view of it, but certainly that is one of the big challenges we've got, and that plays into turnover of staff that we see and challenges around recruitment.
Yeah, fair point. Thank you. Okay, any questions from board members for Ed? Or are we happy to say received and noted? Thank you, Ed. Done? Thanks, everybody. Thank you, Ed. Now then, let's move into item 7, which is the patient experience item from Susanna. But Susanna, you're going to run 7 into 8 and play them as one item effectively, aren't you, to the best of your ability? So over to you.
Okay, thank you, Chair. So I've been to previous integrated care board meetings to provide some updates over the last 5 months about the work that we've been doing through the integrated care partnership to develop our integrated care strategy. So in just a moment, under item 8 in the agenda, I'm going to be talking board members through the key messages that we've heard from that engagement with people living and working across Suffolk and North East Essex, in relation to our integrated care strategy. And also, I'm going to be asking members of the board to formally receive now the integrated care strategy, which was approved by the Integrated Care Partnership on the 13th of January. So just to begin with, I want to share a short film with members of the board. This film includes a number of clips which were recorded using our Suffolk and North East Essex pop-up video booth. Our video booth made a tour of 16 different locations across the system over the autumn, and we actually captured around about 300 clips from members of the public who used that opportunity to share their thoughts around what was important. We asked the questions, what matters to you? And we also asked how we should be thinking differently as a health and care system. So I want to show that film, and then I'll come back to talk you through the key issues that were raised more widely in that consultation, and to tell you a little bit about the strategy as well. So thank you.
And I think there should be some more joined up thinking between the two, social care and health. At the moment, I do have support from MND nurses and consultants and community services such as occupational therapists and physios, but whilst they might liaise with each other, they don't always copy me in, so I don't know who's done what and what's happening. That's the thing I find most frustrating, having to constantly chase up whether it's equipment or response to something or whatever. At the moment, I've got a very difficult health condition I'm trying to come to terms with, and which is bad enough without other stressful situations, which I don't think should be there.
I think what we need to think differently is to think of impacting the community and the society. So many people are struggling because of isolation, rejection, loneliness. So if we can impact the community by giving them funds to do things, a lot of social kind of services there, where people can go for teas and coffees, for interaction and all those things, we will reduce the number of people that we are admitting in hospital.
I think we could be thinking about building more resilience in our communities, more resilience individually. So thinking more about healthcare, how we look after our own health, how we take care of ourselves from going to the pharmacy rather than looking to always access a GP or out of hours or go to the hospitals, and thinking more, how can I build my own resilience for myself and my family?
Sometimes you don't get, because you're autistic,
Yeah.
and you've got things under autism,
Yes.
you find that you don't always get the help that you need.
Yes.
Yeah.
Yeah.
And support that you need, especially in school with your schoolwork and that.
Yeah.
Yeah.
They should help people more. We should think differently to the people that are different, maybe look different, sound different, or in any different way, because everyone is different in their own kind.
When we are identifying care for a group of people, we should ask them about cultural intelligence, how they want to be treated, what sort of beliefs they have in terms of that treatment, because we as clinicians are missing that, and that needs to be respected. Everyone needs to be treated equally in the NHS, whether it's staff, patients. I think if we treat everyone equally, we will get it right, and we will improve in terms of our health outcomes. So I think we need to respect each other, trust each other, work together, and love one another.
My son having autism, the SEN and healthcare don't coincide very well. They don't communicate. There's our paediatrician has been amazing at the beginning, but because he isn't an emergency case, we haven't had a review in since before COVID, and because they're backlogged with the waiting lists, because there's not enough of them. When I was young, I remember a lot of stuff being done through the schools, like the dentist, the eyes, and all that seems to have stopped as well. So that's something that could help parents.
My son's just started reception, and he was able to have access to a flu vaccine at school. So if there are other ways that we can access things within the local community rather than having to kind of make appointments and queue up at the GPs, and they're obviously overworked and overstretched.
One of the areas that I believe is a real challenge for us at the moment is around dentistry care and the ability to access NHS services. Not everyone can afford to go privately, and that's having a big impact on both young people, children, and the elderly across the area.
They should listen to people who have incurable diseases. In fact, they should listen to people in more detail rather than just dismiss them. When I was diagnosed, it took 1.5 years to get diagnosed because I kept getting dismissed by the doctor, as it's just in your mind, it's a temporary thing, blah, blah, blah. And it wasn't until I kept going back that they decided to start putting me through 1,000,001 tests, which I get have to be done. And I was diagnosed with MS. So that's really about it. It's just about communication and listening, and acting where they can.
I suffer with anxiety, PTSD, and depression. Coming from a mental health point of view, I think the NHS should understand how to come across to a mental health patient a bit more with a bit more curiosity, and they should be thinking a little bit more differently than thinking it's your mental health that's causing certain problems when it could be something else, and they should kind of care a little bit more about people who are struggling.
Young black men, they hold things in. They hold things in and they need to talk and let it out, but they think they're going to be judged. It's like it's a taboo thing, but really needs to be looked into. Maybe if there was more people of colour that was dealing with the mental health issues with black men or black youngsters, more role models, this situation will be lesser, because a lot of people don't come forward and ask, and help is there. It's so sad to lose a life.
Being independent, having that ability to continue to be independent in your own home, and to not stay in hospital for longer than you need to, so you're not vulnerable. So, for example, with my mum, she's got me to help her at home, but there's a lot of people which don't have that. So that really, if they had the home help available to them, you know, it's good for keep them independent, but also takes them out of an environment they don't need to be in. You agree?
Yes, I agree wholeheartedly. And I think if you're completely disabled or partially disabled, it's nice for somebody to come in and say, I'll take you out to the shops just to have a look around or a bit of fresh air.
I lost my little brother. He unfortunately passed away when I was 19 to a illness called muscular dystrophy, and he had really great end of life care. So I just want my other family members and my close friends to have the type of care and support that he had if they ever need it.
It becomes very easy for health professionals to talk over you as if you don't exist and as if you're not there or not even in the room, because they're used to their job, they know what they're doing, but they must never forget to explain what they're doing, what you're having done, and why you're having it done. So just to remember that you're an individual, that you're a person, and that actually you're very frightened. And although that's their day job and they've been doing it for years, it's very new to you. You might never have been in hospital before. I've had people to hold my hand when I've been absolutely terrified. And without them doing that, I would not have got through the experiences that I've had.
Care and well-being is more than just the rudiments of healthcare. It's about people caring, people doing the extra mile, people walking the extra mile with you, and also people not giving up on you, even when you're ready to give up on yourself. And I think what matters is the fact that the NHS is such a wonderful organisation, and the people in it are what make it. It's the people that serve everybody every day that make it. And it's the people that care and go that extra mile that make all of us who've had cancer and had healthcare problems want to go on.
Okay, so that's just a glimpse of some of the clips from our pop-up video booth, and just to say that there are many, many more clips that, as I'll go on to explain, we've used to illustrate our integrated care strategy. So the paper that you have in front of you sets out really kind of two key themes that I want to draw out in terms of integrated care strategy this morning. So the first is the key issues that have emerged from that engagement that we undertook with people living and working in Suffolk and North East Essex. As I've explained at previous meetings, we provided a variety of ways in which people could engage with the work underway to develop the integrated care strategy. So huge thanks in particular to both Healthwatch Suffolk and Healthwatch Essex for their support through that process. Also to a number of voluntary and community sector organisations who held community conversations that helped to engage with particular groups, and also for summarising for us some of the messages that came out of those conversations. Of course, the pop-up video booth, but also some of the contacts that we had directly as a team. In total, we actually engaged with just over 600 different people who put forward their views in terms of that engagement. And what I've done in the paper is just to try and summarise some of the key themes that emerged from that engagement. So members of the board may not be that surprised to hear that the first key theme that really came up time and time again was around access to health and care. So timely, convenient access to health and care was a very key issue for many, many respondents. They talked about the need to streamline access, perhaps a single point of access so that people and their carers do not have to have the additional strain of trying to navigate the system. Talked about more local services, including perhaps pop-up services for things like blood tests or health screening, or local health hubs that could provide health and financial advice, access to equipment and other services in perhaps non-health and care settings such as libraries and schools, and you heard some of that on the film. Talked about information and support, things like online information, and for those who may not be that comfortable using the internet, perhaps using other ways to make information available. One idea was around, for example, supermarkets. There were a number of comments around the access to and quality of GP services, and people's concerns ranged from issues around registering with a doctor, access to appointments, access to face-to-face appointments, their experiences of engaging with reception, the quality of GP services, and also the very important role that GPs have around prevention. Another key area was access to urgent emergency care services, and people talked about ambulances. They're very positive about paramedic services, but worried about waits, and also talked a lot about urgent care, and talked about a number of ways in which they thought that urgent care could be improved. Another key area was the issue of waiting for care, so waiting for diagnosis, treatment and support, and the way that people felt that impacted on their physical and mental health. Everything from just simply in terms of causing stress, through to kind of concerns that people's health may worsen while waiting for care, and that they lacked support during that. Talked about the need for joined up care delivered by kind of a competent, caring and compassionate workforce. A lot of the comments, as I've said at previous meetings, were about how important that trusted relationship with health and care is to people, the need to kind of listen and to be able to respond, and to be able to have that kind of can-do response in terms of obviously what people are able to do personally, but also the way in which frontline practitioners are able to kind of lead the system, if you like, on behalf of the person that they're engaging with. The importance of communication and caring. Another theme that came through was the importance around inclusive, anti-discriminatory and individualised care, and the importance of personalised care and recognising people's individuality. And then finally, a lot of people talked about their concerns about health and care. Obviously there are a lot of concerns around at the moment, nationally, around funding, and also their perceptions that perhaps we have something more of a two-tier system, and that our population is growing, and what the impacts of those may be on the local health and care system. But ultimately people talked about, they wanted a system that could provide the best health and care for everyone. And certainly, personally, I'm very inspired by a lot of what people had to say in terms of their vision for what they wanted to see in terms of a local can-do health and care system for Suffolk and North East Essex. So we've taken that engagement, and obviously engagement with the huge variety of different people who engaged through the different work that we did around the integrated care strategy. And the products that we've put forward are a high-level summary of our strategy, which is attached to your papers, and I'll talk you through in just a moment. But also, that is a very short paper. It's just a few pages long, because we think it's really important that we're able to help people to kind of see an overview of the strategy in summary format. But the detail is there as well. So there is then around about 170 pages worth of additional underpinning detail, which are now set out in a more flexible format using our ICS website. So the pages of our ICS website are now containing our detailed strategy as an integrated care system. And I think my colleagues in the tech department are going to put that up on screen, just if you haven't seen it already. So the reason why the strategy is important in that format is that this isn't going to be a strategy that we've now written and we're going to put on the shelf and then leave there for the next 5 years. For integrated care systems, we have the opportunity now to have a much more flexible approach and iterative approach to the way that we develop strategy. So we can continue to develop and evolve our strategy as we go forward. So this is our initial strategy, but we will continue to develop it in a number of ways. So at the moment, the strategy, if you like, is set out under the key headings that you'll see in the summary. So you'll see those across the top of the website. So there's a key theme around working together, best health and wellbeing, health equality, live well, can do health and care, and also some information for everybody about how they can get involved. We've used a really consistent methodology to underpin the content of that strategy. So we've built on the experience that we've had in the system around the use of outcome-based accountability as a methodology to underpin our strategy. You can see in the paper a kind of short summary document that sets out how we've used that, and you'll see that that basically informs the section headings for each of the sections of the strategy. So each section of the strategy talks about the population outcome ultimately that we want to work towards, population outcome measures and indicators, and then it goes into detail around the story behind the outcome through lived experience, published evidence, wider data, and also we've provided some links for those who might be interested in further reading. And then we've set out our ambition. So first of all, what we know matters to people, for example, people living with cancer and why, and those are set out as I statements, and then how we think that things will be different in Suffolk and North East Essex, which we've set out as a number of commitments of we will. The other parts of the strategy is that we've also started to build in case studies and links out to particularly online material which is available across partners in the ICS around case studies of work that is already in place to try and move forward and to deliver on those key themes. And lastly, for each of the sections, we can start to map in and make available and help everybody to find the relevant plans and strategies that exist across different parts of the system in relation to each section. So just to talk you through the summary of the strategy, and it might be that my colleagues can kind of click on each of the drop downs as we go through. So the first of the sections is around the importance of working together. So this builds on all of the work that we've done as an integrated care system to develop ways in which we come together as an integrated care system at a system level through our integrated care partnership, how we work through the NHS Integrated Care Board. It sets out the role now of our ICS Voluntary Community Faith and Social Enterprise Sector Assembly, our Chairs Group and NED Forum, and also provider collaboratives. It also sets out how we've already put in place plans to work together through our 3 place-based alliances. And then very importantly, the arrangements and the work that we've done to commit to how we'll work across the 2 counties of Suffolk and Essex. So ways in which we work together with neighbouring systems across Suffolk and also across the 3 systems across Essex as well. And then a little bit about how we work together in neighbourhoods. Under the first of our aims, which is then best health and wellbeing, this talks about the importance of building resilience, and we've recently had some excellent conversations around the importance of concepts like belonging, safety and purpose. And then it talks about, the need to work upstream, about the importance of being able to live a healthy life, living in a healthy neighbourhood with a good home, good work, education, a good environment and a good local community. It talks about the importance of adopting and maintaining healthy behaviours so people are able to be active, eat well, sleep well, and maintain good mental well-being. And then it talks about the need to be able to avoid needing treatment and care for physical and mental health conditions in the first place by preventing conditions from getting worse, by intervening early or slowing or reducing disease progression. And then being able to manage the impact for those of us with lasting illnesses or conditions, both for ourselves and those who care for us. And also the need to avoid harm from harmful substances and also from avoidable diseases. The next section, which is around health equality, talks about the importance of enabling everyone to have the opportunity of good health and well-being dignity and respect, regardless of ethnicity, race or religion, age, gender, or if someone identifies as LGBTQ+, whether they're living with a physical, sensory or learning disability, or their circumstances, if they're experiencing deprivation, homelessness, or growing up in care, or perhaps living in a coastal, rural or traveller community. And in that section in particular, it explores that both from the perspective of the importance of health equity, being allies, building awareness, assessment, more consistently through the use of equality and health inequality impact assessments, and really building that sense of accountability, weaving right through our system around addressing health inequalities. And then it also talks about the importance of taking a population health management approach that maintains a strong focus on prevention and keeping people healthier for longer. And then taking action at every opportunity through health and social care, through communities and so on, to reduce health inequalities in key areas. And also the importance of taking action, particularly around preventing inequalities for children and young people. The next section is around the concept of live well, is that that everyone is able to continue to live well through each of the live well domains. So there are 6 live well domains: start well, which is about before conception, through pregnancy and birth, childhood and adolescence; being able to be well, maintaining good oral and dental health, eye and ear health, and good health for your gender; and being able to stay well, living with cancer or other long-term conditions, perhaps if you're living with obesity, requiring urgent emergency care, or living with a disability; being able to feel well, if someone is living with mental health or addiction, or as a survivor of trauma abuse; being able to age well, particularly if living with frailty or dementia; and also being able to die well and have the care and support that people deserve at the end of life as well. And then last but sincerely, genuinely not least, is one of the really key themes that came through all of our engagement, was the importance of having a genuinely can-do health and care system that people can trust. And people talked a lot through the engagement about the importance of being listened to and heard, being treated with kindness, dignity, respect and compassion. And then also, as I've picked out already around the engagement, access to support, diagnosis and treatment when needed. And then that support and seeing people as unique people with skills, strengths and personal goals. Focusing on what happens when people move between services, settings or areas, that there's a plan for what happens next, who will do what, and that practical arrangements are in place, and that care and support is coordinated and everyone works well together with me as well. And so for that section, we've really set that out around our core 6 ICS values, our can-do values, which are around being collaborative. So a real emphasis on system leadership and the culture that we have in our health and care system, supporting our people and workforce, and then using, collaborating around, for example, how we can use and link data to support population health management techniques, being compassionate through personalised care, supporting family carers and enabling genuine co-production, being courageous around enabling equity, inclusion and social justice, ensuring clinical and care quality, and also enhancing the roles of clinical and care professionals. And then being community focused, a resilient voluntary community faith and social enterprise sector, the importance of volunteering, community connectors, anchor institutions and community pharmacy, creative through things like digital, data, technology, innovation, research, and environmental sustainability, and cost effective, of course, financial sustainability, and how we use our other resources as well, including our estate. So that is a summary of our integrated care strategy. As I've explained, there is further detail on our website. And the work has not stopped there. So just to conclude, my team now are starting to add further detail in there. There will be a dashboard at the front of each section, which will give a summary of a number of population outcome measures for each section. And those are currently in development at the moment. And then different to population outcome measures are measures of benefits, and those will be added in as well. Adding some further data, so for specific section there is deeper data available, but we're just drawing that out and working out the best way to present that. I'd be really grateful for colleagues pointing us in the direction of further case studies and online resources that we can start to signpost to through this ICS strategy, and also relevant strategies and plans as well. So all of that detail has yet to be added in, but we'll do, and we'll continue with that work as an ICP as we go forward. So to finish, here this morning, the ICP has approved the integrated care strategy. We'd now like the Integrated Care Board to formally receive the integrated care strategy, noting the requirements in the Health and Care Act for the NHS ICB and our upper tier local authorities to have regard to that strategy now as they move forward with their plans and strategies. And also looking for that commitment to continue to work with us, particularly to ensure that the integrated care strategy and the joint forward plan are aligned, and also continue to contribute to that ongoing evolution and development of the strategy. And then finally, and last but not least, to note the very important messages that we've heard this morning from people living and working in Suffolk and North East Essex.
Okay, Susanna, thank you very much. So we've heard initially the patient experience in the video, and how that patient experience and public engagement has then helped develop the strategy, which the ICP has approved and then comes to us today. What I suggest we do, if I may, with the board's agreement, is I'll go straight to Richard for the next item, which is on the joint forward plan, because of course the strategy and the joint forward plan have got to be completely and totally aligned. So if colleagues are happy with that, we'll go straight to Richard, and then we'll go for questions on the combined patient experience, ICP strategy and joint forward plan. So Richard, over to you.
Thank you, Chair. So hopefully colleagues have had a chance to look through the short paper in the pack. And as Susanna said, we're moving seamlessly then from the strategy into, as one of the major organisations and set of partners that support the development and delivery of the strategy, we've now got to set out our 5-year delivery plan effectively as an ICB board. As you may have seen just before Christmas, the national guidance came out at section 1.2. You'll see in bullet point form there the specific requirements that from a national NHS England perspective they would like to cover, of which one is alignment to the ICS strategy, implementing our health and wellbeing strategies, and a series of duties across the ICB that we need to take account of. In section 2, very much similar to what Susanna has just said, we're absolutely looking to align the way in which the joint forward plan is set out to take account of all the facets of what Susanna has just outlined. The kind of the meat, as I call it, in the middle is the 6 live well domains. I won't repeat what Susanna's just gone through, but we've adopted those domains across the whole of our geography. So all 3 place-based alliances are now using the same structure to develop their own delivery plans and to inform the way in which they effectively take forward their transformation, change and delivery work. It's important to note that underpinning that, though, is the golden thread of reducing health inequalities through all that we do. And there is a bespoke significant section of the draft document that focuses on that particular aspect. You'll see at 2.4, again, absolutely the same way that Susanna outlined, that we have looked to align under those 6 live well domains the specific areas that we think we need to bring out in the document. So as an example, under Start Well, maternity prenatal care, and all the different facets of children and young people, all the way through, as Susanna said, to Die Well around end of life care. The way in which we're looking to structure each of those specific live well domains, and indeed many of the sections of the draft document, you'll see underneath that small table. So starting again with why is it important? What do we know about people's local experience? So all the work that Susanna's just outlined, that headline feedback will be playing into our plan to help inform then, importantly, how are we going to make a difference? So that is the major distinction between the strategy and then our contribution as the plan. What are we going to do as an ICB board and a set of partners? What's the commitments there we're going to be made and held accountable for over the 5-year lifespan of this plan? And then importantly for us, how are we going to know that we've done that? So what are the measures that we again can hold ourselves accountable for in terms of the delivery of that plan? It's important to note on that next section that it's not just the live well domains. There's other facets that we need to take account of. And although the language isn't yet exactly the same as what Susanna went through in terms of the structure of the strategy, we've correlated and we're doing more work on that to make sure that we cover off all the different elements that Susanna's outlined in a slightly different structure, as you'll see there, starting with why do we need a JFP, through to how we work differently and what are our enablers to success, alongside a short section in the document for our partners, the organisations around this table and others, to enable to have a couple of pages each to just talk about their own strategy and their own contribution to the JFP. Really excitingly, we have started our patient and public engagement specifically on the JFP. So a particular thanks to Sophie Martin and team and Simon Morgan and team in terms of their work together to start this process. So we've got the Let's Talk SNE website that colleagues hopefully are aware of, which has started to set out particularly the specific commitments that we're looking to make as part of the document in draft form. And importantly, as part of that, we're asking one key question, which is what is the number one priority for each individual that they think the ICB should be focusing on over the next 5 years. And what we'd like to do out of that, and indeed all partners' contribution, linking back to Ed's opening remarks, is come back with, and I'm making an arbitrary figure up, we haven't set on this, the 10 big ideas or the 10 big commitments that we would like to make as an ICB board to our local population. And I think the reason for doing that is the JFP will be large, just to warn you. It'll be quite a large read. I had a few gin and tonics over Christmas reading the draft at 269 pages. You'll be glad to know we are doing a more succinct exec summary, but I'd really like to get to the point where we as a board members could almost reel off what those commitments, those big ideas are, notwithstanding all the other things that we need to make sure that we're covering as part of our commitments as NHS and other partners. We're also running 3 face-to-face events, details on the Let's Talk SNE website and possibly an online one as a mop-up after that. We're going out to the various committees, the various alliance forums, individual partners to ensure that we're also getting feedback as needed, building on the great work that Susanna's already outlined through the development of the strategy. We are slightly ahead of the game. So the guidance that came out before Christmas, we were expecting that we would need to have concluded and published the plan by the end of March. Given the slight delay in the national guidance, they've now enabled local areas to publish by the end of June. Talking with Ed and others, our ambition is still to bring the document to the March meeting of the board and then look to go through our health and wellbeing boards in May. So that's the next available, given they're only every 2 months. That also ensures that we're going in a joined-up way with our neighbouring ICBs. So obviously with Suffolk, we're working with Norfolk and Waveney, and with Essex, we're working with Mid and South Essex and Herts and West Essex. We want to go aligned together to the board. So the eagle-eyed amongst you on that table at section 4.1 will have spotted the asterisk to say we haven't committed to a specific publication date until we've sought some further advice from NHS England around whether, and I suspect we will, publish after it's been to the health and wellbeing boards. So although the board here will have seen hopefully the final version at its March meeting, we have more time until May when it gets to the health and wellbeing board. So really today it's just to bring to the board's attention the work that's underway and that we will be obviously coming back in March with the document. We will be running as part of the February development session for the board a focus on what's starting to come out of that engagement work and other ideas to start to get a longer list of what those big ideas might be. So I'll leave it there, Chair.
Great, thanks, Richard, and a very helpful description of the alignment and the process of getting to full alignment. So, questions, colleagues? I'm going to start with Nick.
Thanks very much, Chair and colleagues. I mean, first of all, to commend the work, really. It's very easy to not do this work when there's so much going on. So it's described as landscaping a garden when your house is on fire, which just occasionally feel a bit like that. But it's really, really important that we do frame the work and do set some ambition. So to commend the work. Just a couple of thoughts. Obviously, there'll be the opportunity for all of us to do more work on the now, as we know, gin-fueled JFP. Thanks for that picture in our heads, Richard, of your weekend, of your Christmas. But I think, I suppose, for me, what's going to separate us and make it different? Because I suspect when you look at all 42 strategies from the ICP and from the ICB in terms of the JFP, there's lots of anachronisms, is what will differentiates these work from anywhere else in the country. And Ed and I had this conversation a while ago about that if I was of a certain age and deciding to retire, what would make me come and live in Snee? So if I had young children, I'd be thinking about schools. I would move, I would do anything to get into the right catchment area to get the best possible education chances for my children. Is there something about saying that the health services, health and care services that we provide in Suffolk and North East Essex will drive people to come and want to live here because they will know that at the end of their life they have the best chance of them dying in the place of choice. They will know that they will remain independent longer in their own home than they might if they lived somewhere else in the country. That if they required acute care, primary care, that the access would be easy. I think a lot of what we hear there, it's bloody difficult to get into health and care, even when you know your way around the system. We know that from all our personal experiences. So is there something about setting the ambition that we as a system would be the place that people would choose to live because of the quality of care that they receive, health and social care? Just a question.
Okay, so I'll take that as a rhetorical question, Nick, and not asking for Richard to give an answer, but imploring the board to think differently, be ambitious, be better, and deliver for the population, both for today and the future. Okay, thank you for that. I'm going to go to Tanya first, please.
Thanks, Chair. Great strategy, great ambition. So thank you for that. It's a real pleasure and challenge to be part of it. I think just a process question for me about how the work gets distilled into the subcommittees to make sure that we're actually delivering, monitoring and governing the right things. And I guess the second part to that is, given the challenges we've got, especially with workforce at the moment, when do we get to the position where we have to decide what we're not going to do? Because there's loads in here and we can't possibly deliver it all. So I just kind of wonder how we work as a board to make sure that we make the right choices and have those robust discussions. And then my final observation was just thinking about inclusion and diversity. We've talked about that as a board and as a team, but actually listening to the film and what people were saying, the inclusion strategy feels like it needs to run across the whole strategy, and just to make sure we don't lose that and it's just pigeonholed to board level only. So no questions that need answering now, but just things we need to.
So again, imploring appropriate prioritisation and stratification of that ambition, whilst not diluting the ambition. Thanks, Tanya. I'm going to go to Steve next, and then Frida. So, Steve.
Yeah, I guess I'd ask, and I share all the observations about the work and the quality. It's what are we going to be discussing in the next year in rooms like this? So if we say that we've got a JSNA that has identified pockets of distinct need and differences across our population, if one of our purposes is to use Section 75 to its optimum and to build partnerships, because we are an integrated care partnership, and alliances, if one of our objectives is to build the resilience of community and primary care and to via resources to different parts and make some difficult resource decisions. And then we have these four overarching purposes, which is outcomes, equity of access, experience, experience and outcome. There's the economic bit, isn't there? The economic resilience, as well as, wider difficult decisions we've got to make. So what I can't see is that next step, which is the discussions are going to happen before they get to this room. And then what discussions do we have in this room in order to do things differently? And the final bit is in the bit that's also missing is the work well. There's the live well, the die well, but actually all our discussions are dominated by the fact that our workforce is really under stress at the moment and finding it incredibly difficult. So what do we add in? And Amanda, I thank you very much for sending the thing around the survey, but that seems to be a key thing we should be spending a lot of time discussing over the next year, which is resilience of our services and those people that work within them. So please, probably a question to the executives rather than the board, but how are you going to turn these into discussions in this room every 2 months that mean we're going to do something radically different? And Nick, you could retire happy that we've been radically different.
Let me ask Richard to comment on that one, Richard.
I can give a view, but others may have a different view. So I think your challenge last time, Steve, was helpful at the last board around the fact that what are the what are the things this board, as I said earlier, are going to commit to alongside all the other stuff that we have to do anyway. In my head, I think if we come up with, say, 8, 10, whatever key commitments overarching that we frame, informed by the public, personally, I think that's where the board could frame its conversations around those commitments. So each couple of months, we could have a particular focus on one of those big ideas, those big commitments, where we actually frame some of the agenda around what are we collectively doing around it. But there'll be other mechanisms through which we could. I think that's partly why on the development session in February, I think that would be a good conversation to have around how do we effectively link the strategy to the JFP, to the actually work of the board in a bit more detail. But I think there's no predetermined view about what those commitments should be. There's a real opportunity for all partners around the table to input into that process. And then I'd really like to run that development session with the chair's agreement to try and thrash out what they should be. And I think that will help inform the board's work.
Okay, let's take that as, I didn't see anybody shaking their head about that, but I'm not saying that Richard's answer there was perfect and complete, although I'm sure it normally is. But Richard, are we happy to take that? Are you happy to take that as an action to work out, if you like?
Yes.
Yeah, okay. Now, colleagues, I've got Frida, Susanna, Patrick, and Craig, and then Ed. So we're going to have to keep going at pace, otherwise we'll lose our time ahead that we were ahead. So let me go to Frida, please.
Yeah, I just want to say thank you to Susanna and Richard. I think it's a really good piece of work, and it's a great strategy, and obviously we instigate the plan from that. But my only thinking when Susanna was talking and listening to the patients is it feels very far removed from my reality on a day-to-day basis, and how are we going to manage the expectation of the workforce within the system and the expectation of the patients within the system where we set such high standards of the strategy, and yet we struggle every day on a realistic sense in terms of our workforce and our capacity and the demand and the lack of funding, and all of those things are coming at me, and then I've got this fantastic strategy and I just don't know how to put the two together.
Okay, so it's more on the how, isn't it? The mechanistics. Yeah, good. Thanks, Frida. Let me go to Susanna next.
I was only just going to add in that, one of the challenges with all of this is, is trying to kind of help everybody to kind of get their arms around the enormity of everything that we're working on in the system. And in actual fact, it's a big privilege to kind of bring together a strategy for this ICS, because there is a depth of thinking in virtually every single area that has developed over time. So you could dip into any particular area. So, for example, how we make a contribution as anchor institutions, the conversations about voluntary community sector resilience, looking at Kirsten or Nick. I can remember years ago coming up with the term can-do health and care, which for me still sums up what it is our public are asking us for, and so on. So I think there's something about at what level do we look at the system, there's something about that strategy, and there's something about the kind of overall principles. And for me, it's, protect health and, enable good health, health equality, inclusion, diversity, all of that, enable everybody to live well. And you can't prioritise any group over any other. It's impossible to do. But that can-do health and care, for me, has always summed it up. It's almost as if we've got one strategy. You could write it in one line. Our strategy as a system is to be a can-do health and care system. And I think maybe we just need to make it that simple.
Okay, thank you. And Patrick?
Thanks, Chair. So several items for me. So one is around the clarity on the scope. So the opening paragraph describes the JFP as how SNE, ICB and partner trusts intend to arrange NHS services. So just some clarity on, is this NHS services or is this the ICB's response? That would be the first question. The second one, and I think the recommendation clearly highlights this, is about, this has got to be about delivery, because otherwise it feels like another strategy on top of the strategy, on top of the JSNA, and we could be continuing to be seen to just be talking about strategies and not actually doing any delivery. There's a question for me on the enablers, such as digital and workforce, and how do we do that as a board, but also how do we bring that into the 3 ICSs across Essex, and how do we make sure that the risks of spreading those resources too thinly or not directing them in a connected way is critical. And then linked to that is around the Health and Wellbeing Board. I fully expect the chair of our Health and Wellbeing Board to ask for all 3 JFPs and look for some continuity and consistency across the Essex footprint. So how do we ensure that? And I know you've touched on that point Richard. I think the comms plan is critical about how we're engaging both with partners. We've seen the links, but actually, how do we go beyond that bit to bring people into Essex? And that comes to the next point. How do you bring this document alive? How do we say to somebody who's living in Essex and in Suffolk, what does it really mean for them? You know, we've got all of these documents, but how does it feel differently? What will be different in a year, in 2 years, in 5 years' time? And I think that's a critical bit. And the last bit is around some of the language. I think we've got to think about inclusivity and how we use some of the language in it. I see in the document it refers to patient and public engagement, but actually some of us don't have patients or publics that we engage with. And some people don't see themselves as a patient or a public. They see themselves as a person who draws on services or a carer or just an individual who lives in the SNE footprint. And so how do we think about meeting kind of national expectations on wording in documents? How do we make it so that it's more reflective of the public here?
Patrick, thank you very much. Richard, I will give you 30 seconds to respond to that, but there was a lot there from Patrick.
I'll try my best.
Yeah,
Susanna might want to come in on some of that, because I don't think Patrick was necessarily all the JFP. It is the ICB organisation's response. So it's this organisation's 5-year delivery plan. And as I said earlier in section 1.2, there's specific requirements in terms of our response to the ICS strategy, the health and wellbeing strategy. So it sits alongside the local authorities' plans and other organisational plans in delivery of the strategy. I think it is about delivery. I think it's not another strategy, it's a plan. It's the 5-year strategic plan. And I think once you've had an opportunity to look, and I'll talk to you separately, Patrick, if you feel it has drifted too much into the kind of the strategy space, then we need to pull that back in, because it's what are the specific things that we are going to put into place to enable delivery of our strategic ambitions, partly outlined in the strategy. There are sections on digital and workforce. I'm not leading on those per se, but colleagues in the room might want to comment around how are we ensuring that we're linking that work into our neighbouring ICBs. I know there's various mechanisms, both in the digital and the workforce space, for doing that. More broadly, I've already engaged with my opposite numbers, as you'd expect, in the neighbouring ICBs and the committee secretariat for both the health and wellbeing boards, and making sure we've got a joined up aligned response, which is why I've pulled back from not going in March and going to May, by which time our neighbouring ICBs are expecting to be ready to go together. Engagement, how do we bring it alive? I would love to hear from others, maybe not today, in terms of how we ensure both the strategy and the plan are a really live document, real thing for the population. I would say actually the Alliance delivery plans that it was remiss of me not to mention are actually where it's going to make more of a tangible difference on the ground. So we're working really closely, Susanna and I, with the 3 Alliance directors and teams to make sure that this is interpreted locally, because there will be different flavours on the ground around how the strategy in JFP is actually implemented. Take your point on inclusive language. The main document actually does use residents. It doesn't use patient and public engagement. That was remiss of me not to pick up that in the covering paper, but I agree with you. We need to get a common lexicon to how we talk about our population within SNE.
Okay, thank you. And Richard, I saw Patrick nodding when you suggested that you get together outside the meeting. So should we take that as an action as well? Some very useful content there as you're developing the JFP. So thank you for that, Patrick. Craig and then Ed.
I'll just come in on one point.
Yeah.
Quickly, Patrick, just to say that there are different ways you can present the strategies, but what I'll be doing tomorrow morning is, together with colleagues across Mid and South Essex and Hertfordshire and West Essex, is presenting the 3 integrated care strategies to the Essex Health and Wellbeing Board. And one of the things that we've done there is to engage some support from the University of Essex to help look at a kind of synthesis of the 3 strategies through the kind of lens of what do they mean for residents of Essex specifically. So there are different ways we can set that out, and we'll be sharing that in due course as well. But I think you're quite right to consider that through the lens that you raise, and be happy to follow that up in more detail.
Thanks, Susanna. Craig?
Thank you. I think it feels like there's a consistency to some of the comments, and that's a good strategy should connect people across the organisation, and it should do that by facilitating people making decisions. And that's as much about what we're not going to do, much as Tanya said earlier, as what we are going to do. And I think there is a risk that the strategy is so broad that I'm not clear what we would stop doing. And you asked earlier, Will, about morale. And I think one of the problems with morale at the moment is people are trying to do everything, and we don't have the resources to do everything to the standard that we all want to do it to. And that's what damages morale more than anything else. And therefore, a good strategy that allows us to properly focus, recognizing the resources we do have, and allowing us to deliver a good standard of care within those resource constraints. That's what a strategy should do. And I think the danger of this is it's not consistent with the resource position we find ourselves in, either financial or probably more importantly in terms of human resource, because we will expect people to do too much if we try to implement this, and that's not fair.
Okay, thank you, Craig. And then Ed.
Thank you. I mean, I think common themes, as Craig says. So firstly, a big thank you to both of you for where we've got to. I think, you know, it's clear that we have to crystallise this into some big practical actions. So we've got the lived experience, we've got the ambition. I think we're clear on the can-do culture we want, but it's crystallising into practicalities. So, you know, the 79 people that have secured employment in Clacton on the back of the diagnostic centre is a great innovation, big idea, practical example. There are others we could talk through now, but that's where we need to get to. And I agree about this might be as much as around, you know, stopping as well as starting initiatives, and that needs to be thought through. The point I wanted to make was around Nick's point, really, is we need to think about how this will interact with the devolution progress in Suffolk, in Essex, because there's obviously new freedoms, new opportunities around resources there, and how can we kind of make sure that this is coherent with the thinking that will develop locally in both counties. So I think that might be a next phase of it, but I think that's a piece of thinking we need to do.
Okay, thank you. So, board members, we are asked to receive the patient experience report and note it, which I think we all did. Very powerful video, so thank you for that. We're asked also to receive the ICP strategy, which I think we're receiving and noting and broadly supporting, but then in connection with the JFP development, we understand the need to show how we're different, to understand the mechanics around delivery and how the board is going to agree those mechanics around delivery, including prioritization and so on, as part of the forward the work to come on the JFP. So with that summary, is everybody comfortable that that is agreed? Lovely. Thanks very much, everybody. Thank you, colleagues, for that presentation. Now, we were ahead. We're now 12 minutes behind. So we've got items 10 through 15, maybe even 16, where the board is asked to note. But could I ask colleagues to be as brief as possible in the presentation, taking the papers as pre-read, but also if there's something you're asking the board to note, but if there's something you need the board to do also, or to agree to do, please make that clear. So item 10 is System Oversight Framework, Performance Indicators and Winter Pressures. Now, Paul is an apology, but Ed, I think you're going to pick this one up.
Yeah, Paul has COVID, so hence his apology. I think this is an item maybe to invite partner members to give their views, but just as I said in my introductory remarks, the UEC system has been particularly challenging, and I think the Q3 performance is not where we would want it to be, and really has pushed us to rethink and to reset our approach going into Q4. Andrew will talk a little bit in a second around how we're working with ESIS, which provide improvement support generally to organisations, but we've asked them to provide support to us as a system too. And the work they've done is to look up and down the country at what's working well and bring all of those elements together, particularly around strong executive leadership and daily oversight, joined up clinical and operational cultures, multiple joined up pre-hospital services, multiple direct access streaming solutions, and empowered on-site urgent treatment centres or equivalent, same-day emergency care, and so on. So Andrew would just give us an update on that in a second. In terms of the joined up approach to pre-hospital services, Neil Maloney, who's the Managing Director of ESNEFT, has taken a lead for me and for the system, looking at particularly how we can support patients that may be on the ambulance stack in the community, and there's an increasing number of patients that we're supporting differently. And also he led a team to Leicester to look at a hub model that's been very successful there, and I'm very keen to land that as one of the big ideas that we'll take forward as part of our JFP. There's no doubt there's a lot more join up we can do in how we coordinate care in the community and manage the urgent care pathway. We're also placing a lot greater emphasis upon safety and looking at this through a quality and safety level, and Andrew and Lisa are leading system safety huddles, which is a new approach we've got, which I think is being effective. And as I said earlier, I think the silver lining around the industrial action is that we saw that spirit of collaboration revive, really, that was very familiar during the pandemic. I think I'll stop there, and Andrew, if you'd like to share your views on working with ESIS, and then we can open up to partner members to give their perspectives.
Thank you, Ed. For those of you who don't know, ESIS stands for Emergency Care Improvement Support Team. It's part of NHSC. It used to be part of NHSI when that existed. And they are well known to the provider members of the board because they've been working with providers for over a decade now very successfully. They've also done a lot of work with regions, but as yet have not worked specifically with integrated care systems and are interested to do so. We had the National Advisor at Urgent Emergency Care come to our UEC committee a couple of weeks ago, who gave a barnstorming presentation really about a piece of improvement work that he had done as part of the regional team in the Midlands, looking at something called positive deviance. Positive deviance is when you look at systems that are performing particularly well, or hospitals that are performing particularly well, and you visit them and work out why they're performing well, and you try and spread that learning elsewhere. It's got some caveats around it. You've got to check that if you're going to spread that learning, that where you're bringing it into is similar. It's not working in a completely different context, but it's a well-validated improvement tool. Ed summarised already the results of what a larger study showed, but essentially there are some key factors that we can focus on to improve urgent and emergency care performance within our system, including visible and meaningful and compassionate leadership, both from executives but also from health and care professionals, and interestingly, particularly medical leadership. Not to negate the value of every other part of the MDT, but there is something different about medical leadership, and I think that's something that I could explore with colleagues in the system. The culture in which our hospital works and how it views its responsibilities and accountabilities with regards to flow through the system was unsurprisingly highlighted, but there was also a role for support, not just support from executive and senior managers within hospitals, but also support from outside within the system, going into hospitals, which gives us something useful to focus on. Standards in terms of internal professional and protocols, internal professional standards and protocols in the hospital were highlighted. Multiple roles of admission avoidance were clearly opportunities for us, but ESIS offer some guidance on best practice of how to make that work. And then lastly, which is where I think we come in, the hospitals that perform particularly well with UEC pathways were ones where they had strong system working. And I think there's an opportunity for us here to leverage the gains that we have produced so far in building up a strong and integrated system to really get some more out of our UEC pathway, because the patients certainly need and deserve that. So that's one piece of work that they're prepared to cooperate and work with us on, and I look forward to developing that further with system partners if you're receptive to that. The second thing is a concept looking at the back door of the hospital rather than the front door, a concept which they call grand rounds, but we might want to call system rounding or something similar, which is a well-recognised tool. And I think lots of us will recognise this when I describe it. Basically, a group of senior leaders working with discharge specialists, patients, and with the different hospitals in our system, do a joint review of all patients in medical beds in the wards, line by line, looking at the reasons why patients that are still in hospital are in hospital, and providing some constructive challenge and discussion around what we can do to change their discharge status from requiring hospital to ready to leave hospital. Where this has been done before, and it has been piloted before, albeit at a regional level rather than at a system level, but still working with individual hospitals, where it's been done, they've been able to show efficiency gains and increased discharges of something like 25% increased on the day where they did the work, and then sustainable gains afterwards as well. From my assessment of what they've done, I think it would be futile to do this as a one-off event. It would first of all have to be repeated intermittently. And secondly, I think we'd have to really program in some proper learning afterwards, leading towards our system improvement strategy, focusing on discharges as well as other parts of UC performance. And again, ESIST are very keen to develop that work at a system level with us. I think this is an opportunity to develop with a credible partner in improving our urgent emergency care standards that we provide for patients, notwithstanding the challenges that we face that we can't change, but there are things that we can change as well. So happy to take questions on that, and also any comments on what might or might not work in that arena.
Okay, thank you very much, Ed and Andrew. Nick?
Thank you, Ed and Andrew. I suppose just on the ESIS piece to start with, Andrew, they've been in with us and done an extensive piece of work. It's important that we link the two. I'm sure that the ESIS seem to be around a lot. There must be some sort of loyalty card system for the East of England that they're working on at the moment, so they seem to be around a lot. But they are good, and there's some really good ideas. My issue about urgent emergency care is that we need to change some of the narrative about why it's important. Because there was the kind of chasing the numbers era, and that was it was helpful in some ways because it focused some of the thinking, unhelpful in other ways, particularly in terms of clinical buy-in and public buy-in. But I think if we start to talk about deconditioning rather than delayed discharges, if we talk about time matters rather than avoiding admissions, if we talk about the fact that if you discharge a patient from a ward, it moves 5 patients into the right place for care. If we move away from the idea that the easiest ward to manage is a full ward, as we know, at least has heard me say for at least 7 years. So I mean, I think there is something about changing that narrative. And I was saying to Ed earlier, I was in another system last week where they don't talk about right to reside, they talk about reason to reside. And it's a really small change, but it really struck me. I've had 3 complaint letters from families saying, what about this right to reside? It's so aggressive, it's so punitive. Reason to reside, a conversation with relatives and others around deconditioning, rather than, oh, you might get an infection, which was, may have been true in COVID, it was certainly true back in the 80s and 90s with MRSA. It's not the issue now. So I think changing the conversation is really important. The second challenge, I think, is we have sadly come to accept the totally unacceptable. So if we'd had 5 patients overnight in A&E without a bed in a pre-COVID world, that would have led to almost a major incident. Now if it's 5, we're kind of, we're really pleased. We think it's a good night. It's not a good night, it's a dreadful night. And I think we've lowered the bar for lots of reasons, some of which are valid, some of which frankly are not. And how do we then start the conversation with our clinical and other colleagues around what we just deem as acceptable without it making sound as though we're just asking people to run faster and jump higher? Because it's not that, but it is about involving people into a different conversation, and then a different conversation with the patients, with the public around it, why the worst place you can possibly be in the entire health system is a hospital, unless you need to be there. They are horrible places. The food's rubbish. We don't let you sleep. We don't let you know what's going on. And I've stayed in some fairly dodgy hotels in my time, but I've never had to share a bathroom with 6 people. They're awful. And we've got to get that message out. They're not safe places. So unless you really need to be there, you just shouldn't be there. Thank you.
Okay, thank you. So there's a lot there about culture and also not normalising poor performance, which I recognise a lot of board members nodded in agreement with. Thank you. Frida.
I agree with Nick. Hospitals are horrible places, but it's also about changing the narrative in general, isn't it? In terms of public. Oh, sorry. It's about changing the narrative in terms of public perception of the entire system, including primary care. And I actually like what you said, Andrew, about system working. And I think for far too long we've been too separate in our thinking and too self-protective, and we need to again change the narrative on that within the workforce. I mean, put patients to one side, the workforce needs to start coming together and thinking that we work together. And so far, it's primary and secondary and community, and we really need to kind of bring everyone so we're working and in a sort of hub mentality, if not in an actual hub. Because there's ways we can help as well. Like, why aren't senior GPs vetting all the referrals into hospital? We perhaps should be doing more of that, from the junior colleagues, and just helping their junior colleagues more in terms of supporting them, and then only allowing those people to refer that perhaps we as more senior colleagues couldn't help with. That's a simple thing, but that does work quite effectively, or could. So there's things I think we can do much more, and we should change the narrative both in patient expectations of the health service, but also in the way that we think about working together. But that's a big thing.
Okay, thank you, colleagues. So I think as a board, we're asked to receive and note the report that we do, but in discussion, we also note the need for, if you like, I'll summarise it as cultural change, but not norming poor performance, and also the overriding importance of system working. And that is all embedded in the ambition that we talked about earlier in our strategy discussion. Received and noted, commented upon, done. Thank you very much. In which case, the next item, support available to children and young people in crisis. And Lisa, over to you.
Thank you. So Richard and I are going to do a double act, and I guess what we're asking the board to note is the current position of children and young people who are presenting with mental health need. That's need for Tier 4 bed. That's need that's been assessed by a psychiatrist and has been through the gatekeeping system. So if we roll back to December 21, we had 13 children and young people who were waiting for Tier 4 beds across that month. It kind of came in a context of decreased numbers of Tier 4 beds available due to a whole range of reasons. Some of the areas were being refurbished, some of them had workforce problems, and some of them had been closed due to CQC enforcement. And as a system, what we were seeing was an increased number of children and young people presenting to our A&E departments in need, which was creating a real system anxiety. Our workforce were incredibly anxious. We've talked about how hospitals are horrible places. Well, when you are a child with a really significant mental health illness, being in an emergency department for days or weeks, just at the point where you need a low stimulus, therapeutic, contained, boundaried environment is probably one of the worst places you could be. So
Families found it difficult and our workforce found it incredibly difficult. So we came together. This is a great example of our can-do health and care system. We came together to develop a crisis protocol. So what the protocol did was agreed principles of how we were going to work together. Before we had the protocol, we were coming together in escalation meetings. There was much anxiety. Things were getting escalated to directors really quickly, and it was creating some real relationship problems between our teams, and meant that the focus was kind of moving away from that child and family in the emergency department, and where can we put the child and young person and their family. So we came together, we agreed the principles, we agreed how we were going to work together and what each organisation's responsibilities and accountabilities would be, how we would care for those children and young people, the in-reach offers from our mental health services. And we're now on version 20 of the crisis protocol, but we've been using it for a few months now, and we've seen massive success. So the numbers have decreased. The protocol may have had some impact on that, but what the protocol has certainly had an impact on is when those children are in the emergency departments, the care offer is better, the care that's provided by the hospitals is better, the in-reach care is better, and I'll come on to talk about the peripatetic offer, but that's improved how we care for those children and young people. But also the length of stay is reduced, so we're not seeing those children and young people normally. I always hesitate because you can bet your bottom dollar, you know, that somebody will be admitted tomorrow and they'll be there for 2 weeks, but hopefully not. But what we're seeing is decreased length of stay. So we had a young person who was admitted to one of our hospitals on the 23rd of December, needing Tier 4. By coming together and just revolutionising the way we work together, we managed to transfer him home with a community support package in about 12 hours. And that was a real success. That was just amazing. So what the protocol has brought together is clear arrangements for when somebody comes into that kind of environment. We also now have a peripatetic offer, which is the new trendy word, peripatetic, where we do a pen portrait of that child and young person. So what's their specific needs? What we were doing before that was commissioning an agency to go and almost security guard the young person in the emergency department. Now we do a really in-depth pen portrait of that child or young person, and we look at what's their needs, what's their family's needs, what's their social, emotional needs, and we commission an agency that can respond to caring for that child in the family context. So the offer is much better. They will go into the hospital and then they will transition with that child into their home while waiting for a Tier 4 bed. That's the ultimate goal. The other thing that has really helped, I think our hospitals will say, is that we now have in each hospital a senior nurse that is there to support the workforce with children's mental health training, education and support. And the last thing that is really great is our mental health trusts have led on training and development across the system to make sure that we're all working with the same knowledge base. So we're on version 20, we've had some success, and just wanted to share that with you. But I'll hand over to Richard for the commissioning.
Thanks, Lisa. Richard?
Not a lot more to say, just a couple of additional. So that's obviously particularly when the young person or child is in crisis. What we're trying to do clearly is put more early intervention in to enable them not even to get to that point. I'd say we've still got a long way to go as a health and care system around that. You'll see in the paper we've outlined some of the specific things we've done in both North East Essex and in Suffolk. A couple of them in specifically, we're nearly at 49% coverage of mental health schools teams. So that effectively is trained mental health professionals supporting directly in our schools, which is a huge way forward, lots more to do. And hopefully, as you'll see within this paper, there's a much greater role for the voluntary care and social enterprise sector in our response, particularly with the peripatetic work that Lisa's outlined, but also some of the earlier interventions that we've started to commission. And our ambition really is that this is all joined up through the embryonic collaboratives that we're forming as partnerships, rather than a kind of a disparate set of commissioning arrangements that I think we've still got a little bit of work to join up on. So I don't think we are ever going to be completely, out of the woods on this, but comparably to where we were even 6-8 months ago, I think we are in a better place. And I think we've just appointed the West Suffolk Band 7 worker this week, which is amazing. So now we've got that key member of staff in each of our 3 acute sites as part of the wider team.
Thanks, Richard. So, colleagues, we're asked to receive the update and note, and then if there are any questions, Sue?
It's not so much as a question as a comment, really, to say I think we are in a better place. I think that the work around the protocol particularly, and the additional flexible resource that we allocated alongside the protocol is a really good example of personalised care in an integrated way across system partners. And we often talk about that, but we don't implement it. And in this instance, in relation to individual children, we have implemented a very person-centred integrated assessment, which leads to an integrated plan, regardless of whoever the partner is. So I think that's a really good example. There are some areas for children with autism without a learning disability diagnosis, without a diagnosis and without a learning disability, where we still have challenges, and there is still a large volume of need in relation to the wider community that we still have to work on. But I think it's a really good piece of work to demonstrate how we can provide personalised care in an integrated way.
Yeah, great story so far, albeit a work in progress, as you all note. Go on, Richard.
Just really quickly, I forgot to say, one of the other gaps that we've got that we're looking at is places of safety. So as Ed mentioned in his opening comments, the STEAM cafes that have opened in Suffolk and the existing cafes that are already in North East Essex, I think there's an opportunity. There are adults at the moment to go further and look at what we might be able to do through those crisis safe havens that we've already commissioned for children and young people. And there is an appetite, particularly from the Suffolk provider who I went to see last week, to do that. So more work to do in that particular, but I think that could be a quite exciting development.
Excellent. Good. Patrick, Frida, very, very quickly, if you may, and then Ed. Patrick.
Okay, thank you. Just a few things. One, it's really welcomed and greatly needed. We've all got examples of cases that we've seen and been involved in for young people. And so finding solutions, more creative solutions, is really welcomed. I just wonder about the young person, and particularly their families and carers, and whether we need to broaden out what more we can do around supporting them, because we're addressing the young person, but actually there are other people working to support them. Just a thought around transitioning into adult mental health services, and how do we build that bridge and make those connections. And then also thinking around the suicide prevention strategies and what more we could do, combining or linking in those particular strategies with this piece of work as well, to focus on that as well.
Okay, so we take that as noted, I think, shall we, Richard? Are you happy to do that?
Just really quickly, families, the peripatetic offer is looking at the family, not just the individual. So it's not the whole answer, but yeah, there is other family interventions as part of that approach. Transitioned out of the answer to that, but absolutely key to ensure that we are joining up more. And suicide prevention, part of the protocol and the work group has involved both of our public health teams from memory. And we are refreshing the suicide prevention work again. I know Laura's keen to do more in North East Essex around a potential post.
Okay, thank you. Frida?
Yeah, I just wanted to say that this is, just correct me if I'm wrong, this is more crisis work, whereas in terms of the work that we do in primary care, having counsellors, CYP counsellors with us is really important as well. And just to say that I work from tendering, as you know, and it's very deprived, a huge amount of adolescent mental health. And we actually commissioned, I know you said about disparate commissioning going on, but then we felt we had no other choice. So we commissioned a CYP commissioner through our council, through our federation, and we're piloting it. And I have to say the enormous difference it's made to us as GPs to be able to refer these children, not quite at crisis, but in need, to the CYP and feel assured that they're getting the help, other than us always just kind of holding on to them and waiting for a crisis to happen. It's been significant to the clinicians, and I think it's really worthwhile to integrate them into the community.
Just very briefly, and Laura might want to comment two aspects of that. So I should have mentioned, we're also investing in, I know you know this, Frida, mental health practitioners for children. So building on the adults posts that we've got in primary care as that interface into secondary. I know there's some further work in North East about augmenting those also with counsellor posts. And there's some work looking at how we might be able to take that forward. I think obviously one of the challenges is the funding aspect on top of the mental health practitioners that we've committed to.
Okay, thank you. And Ed.
So just very quickly, I think this is a great kind of case study response to Craig's challenge earlier about, you've got a strategy, but how does it become meaningful for the frontline staff, for the population? And I think this is a great example of what we need to do in lots of different areas of health and care. It's, whole system response. It's can do, proactive, really good.
Okay, so colleagues, I think we've received this report and progress enthusiastically. We note that it's a work in progress, of course, but that and version 20 at the moment, I think you said, Lisa. We hope you don't get up to version 120, but nevertheless, it probably is a never-ending job for improvement, isn't it? But that we are grateful for the work done so far. We're encouraged by the outcomes and the progress that you're able to examine, to illustrate to us. So thank you for that, received and noted with those comments. Let me just do a little bit of meeting management. The next item is the Send Inspection Framework update. And I'm wondering, Lisa, if we could take that as read and go straight for questions, if there are any. And the reward then is a short tea break. But when we come back, I think we need to go to Maddie for a quick 1 minute on the IES highlight, because you've got to go shortly after, haven't you? So colleagues, are you happy with doing it that way, Lisa? So Lisa's offering us the update on the Send Inspection Framework, straight for noted. Are there any questions?
Just a brief question, which is, when we get the report back at the end of it, is it provider specific, or are there recommendations that come to this board for us as a board to pick up and act on?
So when the inspections happen, and obviously we don't know when those inspections will happen in Suffolk and in Essex, the report will be for the system. So there will be specific things for health to pick up, which we'll need to obviously address, but there'll be one report for the system, which we'll bring through here.
Okay, noted. Okay, thank you. So, colleagues, it is, now my clock has just ticked over to 11:12, so can we come back at 11:20? We'll have a 1 minute from Maddie, and then we'll go back into the agenda with Amanda and Ganesh for the AHP item. Everybody content?
Chair, would
Thank you very much.
Would it be possible to let Maddie deliver now, because I know she's got to be in Felixstowe at 11:30.
1 o'clock.
1 o'clock.
I have to leave here at 11:30.
11:30.
All sorted? Happy? Yeah, very good. Over to you, Matt.
Thank you very much. Feeling the pressure now. So I just really wanted to focus on the 10-point plan which we have agreed for the coming quarter. Happily and positively, some of the achievements that are noted in the report have been mentioned by Ed and by other colleagues as well. So our executive delivery group and the committee has agreed these 10 priorities, the first of which is to focus on stabilising and improving our operational resilience, specifically including urgent and emergency care, working across the whole system to do so. And our tactical cell has been fantastic in that, in supporting that work. The second is really to focus on our integrated neighbourhood plans. We do have a diverse area in terms of our communities and our geography and need. And so moving forward to the next stage of our integrated neighbourhood plans based on population health management is really critical, and we will have those completed by the end of this year. The next is then building on those to really focus and expand on Ipswich and a plan for Ipswich and for Felixstowe, which is where I'm pleased to be going after this meeting. Recognising the holistic needs that we need to think about in terms of economic and social developments, housing developments within the areas, and the health and care needs and the wellbeing needs of those communities. The fourth is really looking within the ICP's work on the voluntary sector, what we specifically need to progress within Ipswich and East Suffolk. Next, working with our colleagues across the whole of the area is looking at the forward strategy for primary medical care within, of course, the system context. And we hope to really progress that in the next month to start that work. Next is to receive the safe accountability for pharmacy, dental and optometry commissioning. And so a great deal of that will be done across the whole of the ICB, but it is really important that we look at the integration opportunities within each alliance area and indeed within each of our integrated neighbourhood teams. And I think we're making excellent progress on that. Seventh is to focus on mental health and the community mental health model. And this is really very much working in partnership with our Suffolk GP Federation, NSFT and the integrated neighbourhood teams. And we really now have some flagships of success, some integrated neighbourhood teams in Ipswich and in Woodbridge where this progress is being made. The eighth priority, where we know we need to do a great deal of work, is looking at our workforce operational group and the estates group and really making sure that we are responding in an alliance community to the opportunities that are available through the work that Amanda's leading across the ICB. And we particularly want to make sure as well that we're doing that in partnership with the University of Suffolk. The ninth, it's obviously crucial, and we have talked a little bit about it, economic resilience was mentioned, is looking at our forward strategy, forward financial strategy. And last but not least, as mentioned by Richard and Susanna, is our forward whole plan for next year for the Alliance within the framework of the ICP and the ICB strategy. So just to say, I think that these are very much agreed priorities and the focus for our action. Thank you.
Maddie, thank you very much. Any questions for Maddie or received and noted? Done. Lovely. Go on, Edward. Yeah. Put your microphone on.
One comment as Maddie's chair that all these are very important issues, but probably one of the most is to make sure that we get some plan for making sure the voluntary sector in our alliance is treated properly as a partner rather than just a go-to when there's an issue.
Yeah, noted and agreed, I think. Yep. Done. Thank you very much for that. Okay, thank you, Maddie and Edward. In which case, back to the running order for item 13, the AHP leadership item. I'm going to go to Amanda, and then I think we're going to you, Ganesh. Amanda.
Thank you very much, Chair. So I'm really pleased to welcome Ganesh to our board meeting this morning. Ganesh and I have been working together for the last couple of years, and I'm delighted that Ganesh will share with you his great work on how he and colleagues have embedded AHP leadership across the system. So over to you, Ganesh.
Thank you. Thanks, Chair, for inviting me to talk about AHP leadership across the system. I think it goes without saying that chief AHPs in situ are central to improving quality of care, patient safety, AHP-related workforce issues and clinical experience within NHS trusts, and equally in the care setting also. Research, and these are fairly new roles over the last 2-3 years. So research is demonstrating we still have quite a deep set variation of the roles itself, the banding, the title, the position within corporate structure of these roles, although it is starting to reduce and we're getting more numbers within systems, but there's still a growing need to have more of these director roles or chief roles within trusts themselves. The role of the chief AHP can broadly be described within the domains as illustrated there, and obviously you've received a copy of the slide set, but again, it is still growing in terms of portfolio. There's an increasing expectation for chief AHPs to act as system leaders via the sort of ICS AHP architecture. So we've already got our councils which work and operate as nursing cabinets, and our AHP faculties also. So again, across systems, there's a variety of maturity levels, and unfortunately whilst we had 2 leads appointed from the university, their contract had come to an end. So we're looking at opportunities to grow that and develop the faculty further. So there's still national work around benchmarking. So there are some established, as I said, mature systems looking at ICSs or organisations where there are chief AHPs in situ. But in particular, when we look at the ratios of AHP strategic leads in comparison to the nursing and medical model, we're still quite poor in that area. But where we have got colleagues in situ, and it's very well demonstrated in our own system with the 2 acutes, so one of the acutes having a director of AHPs appointed with a strategic lead beneath her, the quality of the workforce data, the redeployment of staff and the recruitment strategies have been far greater. Unfortunately, with the trust within our system, not having that director role has meant we've potentially missed out on some funding opportunities from the arm's length bodies, particularly around international recruitment, OT and ODP workforce development as well. So I think as a system, we really do need to start stepping up our opportunities and energy to ensure that all of the key providers have strategic leads or directors in particular. Again, so I won't read through all of the slide here, but splitting it into the quality and workforce metrics, with what's been described earlier this morning as well, the chief HPs will be key in terms of talking about delayed transfers of care, long length stay, and the model that Andrew described earlier on around the grand round. It would be good to have that AHP voice involved in that, particularly as a lot of the discharge teams are led with our OTs and colleagues. So we have our local and regional strategies which dictate what we're doing, but we work towards the national strategy, which has come out of Suzanne Rastrick, who's our Chief AHP Officer for England. And so this strategy is the second national strategy. It's a 5-year strategy. And I worked closely with the chief fellow that pulled this together. So this was 12 months plus of work, of crowdsourcing and co-production. And actually, in terms of the healthcare piece of work and strategy, it's one of the largest in Europe that use this methodology. So the AHPs deliver a strategy. The process is obviously to maximise the AHP's contribution to improving health outcomes for all, fitting in with what Suzanne was describing earlier on, providing that better quality of care and improving the sustainability of health and care services. The strategy itself is made up of 2 key themes. So we've got co-production at the heart of it, and moving towards anti-racism. And the AHP community are working very hard around those pieces to develop that further. So we've got well-established EDI or ethnic minority networks within each system and region as well, and that will feed into the organisational networks as well. We've also got a group of enhanced foundations there, as you can see, and particularly, with our models of wanting to ensure we've got the right workforce with the right skills in the right place, and there's a huge emphasis on digital and research and innovation as well. And at the centre, we've got the 5 areas of focus: people first at the centre, social justice, and optimising the AHP voice as well. So the national team actually looking at ICS's suggested for our AHP faculties, and again on the original slide deck there's a brief sort of paragraph setting out what our faculties set out to do. But again, some of the questions they've put to us for the next 12, 18 months is actually looking at our work as AHPs and faculties and focusing more on the added value there. Is it a case of looking at transformation plans and ensuring actually we've got the correctly trained staff in situ, developing training and education packages that fit with those pathways, and also having that better link and relationship with the universities to fit recruitment onto programs versus the workforce projections within the system. I think there's still a bit of a gap there, and we can work closely with the nursing and medical teams to consolidate that further. Again, just a brief slide on what we are doing as a faculty with HE funding. We've recently received £15,000 for our OT workforce project to work alongside the national OT workforce development piece as well. Fortunately, that's something we've just got that in, but it's going to be spent up by March. So we're working hard on putting a programme together around that. Again, so a list of our deliverables. So these are 12 deliverables as set out by the HEHP national programme. The areas with the stars on are where we're focusing currently. So it's not particularly that we're prioritising this. This is where we see that there needs to be growth. So we want to ensure that the support workforce voice is amplified and key in decision making and apprenticeships, education, etc. And these are obviously potentially our future registered workforce as well. So we're doing a lot to support that. Just a sort of crude organogram, as it were, of how and where we sort of position ourselves and can influence. You can still see we've got gaps in the alliances, primary care, education, etc. So we're still early in our journey, but I would look for the system to support this growth further. There's clearly a lot we can continue to do to influence the system. We do have very good links into the national team at NHS England and Health Education England with the capo and the deputy capos, and then we have a strong regional leadership team also, which I sit on that board, and that obviously then informs our local system. So again, what I think, as I've already highlighted, we do have gaps in formal AHP leadership, particularly at West Suffolk Hospital. So again, whatever we can do as a system to push and influence, having a director of AHP alongside the nursing and medical directors there. We need to look at formal leadership within our AHP faculty. We need to, that I think is the most important bit within our system, having a sustainable model of funding the faculties. We need to increase social care involvement. We're doing the best. We've got formal members on our councils with the universities and social care as well, and that needs to grow. Primary care also. I think the primary care side of things is that we don't have senior leaders there to support our work. With Professor Shenton, we're looking at potentially, with our new starters, developing a new to NHS leadership development program, particularly with international recruits as well, so that'll be open to them. And I think it's about, if we are setting a way of working within our system, having that sort of ambition and role modelling early doors alongside our preceptorship programme. Common Purpose is another company I'm speaking to about inclusive leadership programmes as well, so we can develop and consolidate our the diversity of our leaders within our system. So again, a slide I've pinched from our chief fellow. So that I think, you know, you can see all of this together with our AHP community working alongside you all has the greatest impact. Thank you very much.
Okay, thank you very much. Nick.
Thank you very much for the presentation. I thought it was really interesting. Just while you were talking, and I know you did touch on it in one of your later slides, I was thinking about the rising number of AHPs in primary care and in community care, given the PCN enhanced service where we actually have funding available for non-GP workforce. Within my organisation, there are a couple of physician associate leads, but I was just thinking whether or not it might be useful to have a conversation about leadership in AHPs in primary care, and I'd asked that question prior to your last slide. But also, one of the things that we've been doing that's quite innovative and helpful in recruitment and retention of AHPs is the variety of clinical work being in primary and secondary care at the same time, and joint posts and a few things like that. So I just wondered if there was an avenue we could explore to try and improve that for the system as a whole.
No, that's great. And speaking, I've completely forgotten Andrew's new colleague, who's our associate medical director in the Alliance. Who's just joined us, Andrew? Is it David? Yes, I was speaking to him about that exact thing. All I will ask is don't grow my portfolio. Physician associate, psychologist, don't formally fall under allied health professions, but absolutely we need to be working alongside them in terms of developing that model. It's not standardised. Particularly in primary care, we see a huge variation in terms of competency and leadership there as well. But absolutely would value a conversation with you about that. Thank you.
Okay, we'll take that as an action. Thank you, Steve.
I wonder if we should think more broadly on how we build on the work you're doing. So in a mental health provider, you see AHPs as probably one of your biggest resources, and actually seeing a doctor is a failure, because actually there's very few of them compared to the number of other professionals. And if we were going to think really innovatively about direct referral pathways, which aren't going to go through general practice, but through community hubs, if we were going to build a workforce, and as a doctor, I used to refer an awful lot of people onto AHPs who had waited months or weeks to see me just because they hadn't reached the right person, and which was someone like you. How might we think about how we build on the dentistry social enterprise structures to actually say, okay, we are now going to work in a different way with a direct referral pattern that opens the doors to growing through social enterprise structures, a community of practitioners that can treat an awful lot of patients in a more innovative and different way. And maybe also in parallel, we're doing some private practice as well, where actually there are parallel income streams that currently I think people are going to practitioners. They may not have the real confidence, have the continued professional development and training, etc. So I just think this could be a really big area for expansion.
Absolutely, and one of the things I've put in my role to the professional bodies actually is that sort of closer engagement with ICSs to influence that, because I think, you know, they'll help with education, but actually they're not immersed in what local healthcare architecture looks like, and I think that will then help standardise what primary care looks like. With many GPs will say to me, well, why do I want an advanced practitioner when I've got a nurse practitioner, a physician's associate? Why do I need an extended scope physio or a first contact practitioner? So it is around sort of modifying that, and public perception as well. You know, a lot of the patient service users don't fully understand the different roles, and you know, myself as a podiatrist, equally trained to deliver foot and ankle surgery, people don't always see the benefits of that, yet we're absolutely immersed in the vascular and diabetes pathway in terms of limb salvage and reducing, you know, hospital admissions and amputation rates as a result of that.
Okay, thank you. I've got Sue, then Peter, then Andrew. Sue?
Thank you, Chair. I don't think it's just the public don't understand the different roles. As a local authority partner, and have been, as you know, working closely with the health system for a very long time now, over 15 years, I don't understand the distinction, and I'm not asking you to explain it now, between who's in this group, who's in the nurse group, who's in the clinical, who's in medical. I'm getting confused. And the reason why I'd like a further conversation probably outside of this meeting is because if there is potential to use the this workforce in a way to supplement or provide alternative pathways, I think we need to carefully think about which of the social care workforce and which not is in that group, and for what reason and why, and is it just the therapies like their OTs, or is it broader than that, based on what would make sense in terms of the pathways, rather than another kind of definition of why. And so I think there's a bit of work to do, a granular piece of work to do, to break down the different varied and types of role in social care and work out where that interface makes best sense for how, what and where our ambition is for the future, rather than kind of not be clear on that. I think we need to do that.
So just, Ganesh, tell me if this isn't a good answer for you on that one. Are we happy? Well, happy is not the right word. Do we note Sue's comments? And actually, you're asking for a piece of further work on this, Sue, as a system, but as a board as well.
Yes.
And perhaps we ask the exec team to come back with a proposal as to how we get that level of understanding and increased integration and increased utilisation and so on.
It's about where the join up makes sense for the benefit of the system, or where it doesn't, and therefore there needs to be a granular understanding of what the different roles in social care are in order to achieve that.
So we'll take that as a further piece of work to be done. Now, whether that turns into a development session item or whatever, we'll exec team make a recommendation to us as appropriate, but noted that needs to be done. You happy with that, Ganesh?
Yeah, no, absolutely.
Yeah, great.
Thank you, Sue. Yeah.
Peter?
Thanks. So just one example of integrated working I just want to bring up, and if we're setting our vision out, if you go to Brandon today and you need therapy, you go to the leisure service. The therapy services are embedded in the leisure service. They've got particular suites set aside, and it helps in establishing those long-term behaviours that we're looking to support. And I think in terms of our strategic vision, and we're really short for space for primary care, just something to note, I think, with our district council heads on all those leisure partnerships that ahead of us, and I think we've sort of scratched the surface of what we can do in that domain.
And developing your theme there, Sue. Yeah, thank you. Andrew?
Thank you, Ganesh. It's really, really interesting. I think we need to acknowledge there's a wider health and care professional leadership programme also in operation, and can I propose that we adopt your work as part of that wider programme rather than running the two things in parallel.
Okay. So, did you want to come back on that?
No,
you haven't.
totally.
Noted, yeah. I think we've been, as a board, we've been very pleased to receive this update. Thank you very much. We can see that actually it presents a lot of further opportunities in many different respects, but we'd like to give the exec team time to develop the thought process as to how we make the most of those opportunities. Indeed, how we encourage and achieve mutual understanding across all system partners. So should we take that as an action? Agreed? Lovely.
Excellent. Thank you, Chair.
Thank you. Thank you very much. In which case, then let's move on to the oral health and dental commissioning proposals. Richard, is there any chance that we could receive this and go straight to questions, noting how committed the board is to improvements in dental care?
Yeah, absolutely.
Are you happy to do that?
Colleagues are happy with that, yeah.
Any questions? The paper's simple and hopefully illuminating. Kirsten, over to you.
Thanks, Chair. And thank you for the paper, Richard, that we didn't hear just now. I wanted to make a comment about system working, and I think this is a really good example of where we could go even broader with system working. Poor dental health is very much related to poverty, and you've got a whole voluntary sector who are linked in with families who will be experiencing hygiene poverty and aren't able to sort of keep well. And I think there's just more we could do really in terms of using the voluntary sector and districts and councils probably, but definitely the voluntary sector and getting to families and supporting A, with products, but also B, with any educational material we might want to sort of hand out.
Good point. And I saw a lot of nods around the table as you were speaking there, Kirsten. Do you want to respond to that, Richard?
Yeah, just very briefly, absolutely supportive of that. So without going into the detail, the papers colleagues have read it. This is about issuing of the grants to the organisation, to the councils in there. It's not saying that we've absolutely nailed exactly how every pound's going to be spent, but you'll see in Appendix 1 to 3 the broad outline of the areas that we want to look at. There's also an open invite. We can talk later, Kirsten, about the dental task force that I'm fortunate to chair, which is bringing a set of partners together around this agenda.
And Ed would like to make a comment as well. Over to you, Ed.
I think it would be good to, I think you've just said that probably, but set up a formal meeting with you, Kirsten, as in your role at the Assembly. Because to be fair, I don't think we've explored the opportunity with the voluntary sector in this area enough yet. And I think, exciting with this programme in the councils, but we could certainly go a lot further.
So we'll take that as an action. Thank you, Kirsten, for raising that. Any other comments, colleagues? Otherwise received and noted and indeed supported. Thank you very much. So on to the highlight reports. We've had Maddie's. I'm going to go to Laura next, North East Essex. Over to you, Laura.
Thank you. I just thought I'd highlight some of the work that we're planning on undertaking in February and March. I think it speaks to much of the conversation that's happened this morning at board. We're in a position that we're about 6 months through the ICB, beginning in July with the closure of the clinical commissioning groups. We've also recently appointed a new chair, Councillor Mark Corey, who's a Colchester councillor. And we're also aware that there's been a number of changes within our partner organisations in the place-based partnership, including a review of a number of our partners' organisational strategies. That's also taken in the context that we have the Essex Health and Wellbeing strategy, we've got the public health strategy, we also have our own ICP strategy being developed and the JFP, so felt it was time to pause, reflect and really take time to consider where we're going forward as our place-based partnership. So we're lucky to have secured the support of the Local Government Association. So the LGA have agreed to facilitate a series of workshops for us that are being undertaken between February and March. The first workshop is going to focus on what we've done to date and our strengths, but look at very much the opportunities that we feel we have collectively at place covering North East Essex. And this will also bring into account the work that was done on the Case for Change originally a number of years ago, but also look at some of the future opportunities. I've said that we really need to focus on using an outcome-based approach and also some of the assets that, the asset approach that we take in North East Essex. The second then will focus on those organisational strategies and the priorities and those that we feel we can only do together as a collective system in place. And then our third will look at new ways of working and the innovation and transformation that we need to undertake together as a partnership, including better use of our estate, joint roles, and looking at potential around pooled budgets. We'll also be using the anchor approach that the Essex Partners Board very much support through their Sharing Prosperity mission. And of course, Ed Garrett is one of the sponsors of the Essex Anchor Network. So we're very keen to make sure that we're looking at all of the pillars around how we can maximise the opportunities that the public sector collectively have to make a difference to people, improving population health outcomes and reducing inequality. So that will be undertaken and should be finalised in March. And we will then take that work forward through a series of longer term, more sustainable delivery plans. Thank you.
Thanks, Laura. And any questions for Laura? Noted and received with thanks, Laura. Thank you very much. Peter, Suffolk.
Thanks, yeah. Just in terms of the delegated function, just a couple of things I just want to highlight. We received a paper regarding primary care estate, and we've got about 75% of the recommended estate quantity for a traditional model of general practice, and we've got substantial growth coming, and particularly to Wimberry today, we've got about 20,000 more residents forecast for the next sort of 16, 17 years, and similarly in Haverhill around 10,000 residents. So it's a big challenge ahead of us, and we've got to think about with workforce, digital and premises, quite how we're going to do that. Now that's just the West Suffolk story, but I'm sure versions of that will play out across all. But we had that challenge set out for us. Another challenge that we've sort of identified is the prescribing levels and obviously the way that we've been working particularly the last 6-8 weeks with antibiotic use, and we put a lot of support around practices who had some of the highest levels of activity with the strep A work. But we're looking at our prescribing levels are quite high. And so we're starting to do work with practices, and particularly as partners across the hospital and primary care sector, to think how can we get back on track with some of our prescribing budgets. I know we've got the finance report coming later, but in terms of our delegated functions, those are a couple of quite large items for us. In terms of the alliance working, we are sort of ambitiously bringing each month the different live well domains and how we're getting on trying to implement those and what it means. And I'm sort of virtually, I'm imagining that Ian Gallen was sat here, because this is what he would be saying now, is he keeps pulling us back into, look, don't miss the district council connecting opportunities, because we very easily go into our joining the NHS and joining up with social care. And I think we have lots of opportunities to districts. And the one that we're really getting behind with the county colleagues is healthy behaviours, and thinking about when we're trying to improve lifestyles across West Suffolk and across Suffolk, there are some delegated budgets and new ways of working that we're doing county colleagues are really exciting. And I'm sure we're doing across Suffolk, but we'll chime across North East Essex in terms of weight management and physical activity.
Okay, thank you, Peter. Any questions, Steve?
I'm just struck hearing the 3 reports. We get the same in the Quality and Safety Committee. You get this amazing breadth and depth of work, fantastic. And it's really heartening to hear what is happening down in a place-based level. What's the role of us as a board to kind of integrate those 3 reports, and what's a common theme and what might be a common discussion? So, and I think this is where we're going with quality and safety, because we just see 3 snapshots. So I would encourage, is there some discussion that could be had ahead of a board meeting or with the executive that at some point says, okay, this is something we would like you as a board to discuss, because it's an enabler for us to go that bit faster, further, whatever. Just that's our role, to integrate it.
Okay, and should we say noted? Great. Yeah, thank you, Steve. Any other questions, points, comments? No? Received and noted again. Thank you, Peter. In which case, item 16, the Integrated Care Academy Annual Report. Amanda.
Thank you very much, Chair. It's really come here to note. This is the second year the ICA has been going, and I think they're going from strength to strength. So a lot of what's contained in the annual report is lifted from their 5-year delivery plan. So really, Chair, it was here to note for board members. Thank you.
Okay, to receive and note. Any questions, points or comments? Ed?
I mean, they've been very successful very quickly, but we just need to make sure the academy is aligned to the priorities and big ideas that we're going to emerge in the next few months, just so that everything is behind that.
Okay. And agreed with that, I think, from a board perspective. We're always supporting alignment, aren't we? So thank you, Ed. Anything else? Noted. Thanks, colleagues. So item 17, finance report. Over to you, Howard.
Thank you, Chair. I'll take the paper as read and just provide a quick update on where we are with this financial year, and also give an update on where we are with the planning cycle as we go into 2023-24. So firstly, with respect to this financial year, a quick reminder really that our allocations equal about £1.9 billion, and the ICB financial target is to break even against that budget, and that's the same target that the ICS has overall for its partner, NHS partners. We have been consistently forecasting that we're going to deliver on this target, and indeed that is still our forecast at the end of December. So overall risk against delivering this plan, we're now assessing as low. So we think we will deliver the plan, and barring any significant unforeseen shocks, I'm not expecting our forecast to change. This position is also reflected amongst all our ICS NHS partners, with ESNEFT and West Suffolk and the ambulance service also reporting low to zero unmitigated risk in delivery of this year's financial target. I think it is important to note that some of our neighbouring ICBs are coming under greater financial pressure this year. And I just want to make the point that we shouldn't take the delivery this year for granted. I think it is a testament actually to the hard work and commitment to partnership working that it definitely exists in this system. And aside from demonstrating good system financial grip, this consistent performance, we've also had confirmation will attract a £5 million capital bonus as we go into next year. So there are rewards for that. However, much of the overall delivery in this financial year, combined with the sort of challenging performance environment that the whole system has been working under, as we've largely delivered through the application of some non-recurrent solutions. So as a consequence of this, we do go into next financial year with an underlying recurrent challenge and less flexibility with which to deal with that. So this coming financial year into 23-24, we can expect to be more difficult than the year that's just gone by. So with respect to next year's planning, we're still working through the implications of the guidance and the allocations, but I can give the following highlights. First of all, our total allocation is going to grow to just over £2 billion. And the underlying growth, that's approximately 90 million, is offset by central allocation adjustments to bring systems back to pre-COVID funding position. So what that means is effectively is allocations being stripped out of the system, approximately about £40 million. And this is known as the convergence adjustment or COVID adjustments that are coming out of systems. So we can really think about the allocations we're getting next year, really to cover an expectation of inflation, but not a lot else. And this does seem to be in tune with some of the national messages that are coming through from NHS England around focusing on improving productivity to deliver any additional growth. The good news, I think, for the SNE system is that those adjustments are genuinely non-recurrent for us. But most other systems in England, particularly on the convergence adjustment, are going to continue having to have that adjusted from their baselines for the next 2-3 years. So again, we're in a fortuitous place from that perspective. And I think I just want to reiterate again that this system is, I think, well served by some really excellent relationships across the finance community. And there is definitely a good intent to work together to resolve some of these difficult challenges as we go into next year. And I think the final thing to say is that I would expect to bring a much fuller report to the March board, obviously on the 2023-24 financial plans, and also just listening to the ICB strategy and joint forward plan today. I think there's a bit of work just to make sure we're connecting the dots between the resources that we have available into next year and beyond, and the strategy. So happy to take any questions.
Thank you, Howard. And just before I go to Edward, I have a question from Steve Clark in absentia. Steve notes the performance and obviously is pleased with the forecast outcome for 22-23, but he notes the slippage on the CIPs and asks what could we do to diminish that problem to prevent it reoccurring in future years.
That's one of the things we are definitely working through as part of the planning for next year. But, yeah.
Okay, so noted and on the work plan.
Absolutely.
Okay, lovely, thanks. If I just go to Edward first, Nick, if I may. Edward.
Thank you very much, Chair. I was just going to update the board on the governance aspect of what Howard has been talking about. Under Howard's leadership, we have created a finance committee which sits between the work being done at the executive level and this board. And it's met twice now. I've got the honour of chairing it as an independent. Firstly, to define the terms of reference, and secondly, as to have a look at exactly where we were in terms of financial performance. I think the most important thing, as Howard said, is that it's quite clear that the meeting will be very effective. Everyone is very, very happy to be working with each other, being honest and open about their problems. It's also quite clear to me as an independent that I go a little bit further than Howard has mentioned, that whilst we'll hit the targets that we've set ourselves for 22-23, Some of that will be affected by reducing balance sheet strength in terms of providers, which puts even more pressure on the 23-24 budget setting process. And it looks as though that will be quite a difficult and quite a challenging conversation as we move through into the next quarter. But really this is to allow the board to be assured that that governance process is now in place and working well.
Excellent. Thanks, Edward. Thank you for that update. Nick.
So in some ways it's linked to Edward's point there. I mean, I think the challenge going, I think we just need to be, not to shy away from the challenge that we're facing going forward. So for the last 3 years, we've had an all-you-can-eat buffet of funding, and people have forgotten, I think, about our responsibility around financial constraint a little bit. Certainly in the organisation that I have the privilege to lead, that there's and looking at the business cases that are coming forward from our divisions, you think, well, what planet are you on in terms of expecting that level of growth when we know we're constricting and not a growth market? I suppose my question is, perhaps to Edward or to Howard, through you, Chair, is are we starting to think about system-wide waste reduction rather than CIPs, and it's a better way of looking at it, system-wide waste reduction rather than the individual organisations approaching it and are looking at the opportunities around some of the interfaces, because I think that's probably where we're going to have. Yes, we'll have our own productivity efficiency, that's absolutely going to be driven from the centre and elsewhere, and we know there's a lot to go at there. But what are we doing at a system level? Has there been some thought through the finance community about how we might approach that?
Over to you, Howard.
I think that's an excellent question and a challenge, and the answer to that is yes. There is certainly a willingness amongst the directors of finance in the system to develop a more systematic approach to looking at those sort of interface opportunities, but also I think to challenge ourselves as partners around the delivery of our own internal cost improvement as well. So I hate to say there's another group, but we do have a group that's been set up now called the Financial Improvement Group, and one of its tasks is going to be to, I guess, hold our collective feet to the fire in terms of are we delivering around some of these interface SIPs. But I'd also like it to take a role in supporting some financial evaluation around some of the investments we're also putting in. So I'm thinking about things like the discharge funding, for example. How effective is that? And so that group is being developed, and we've got good buy-in, I think, from the finance community.
Okay, thank you. Any other questions or points? So received and noted, and also perhaps in summary, noting the 23-24 challenge, which is going to take some considerable effort from all in the system to address in appropriate ways. Agreed? Good. Thank you very much, everybody. In which case, item 18, the BAF. Over to you, Amanda.
Thank you very much, Chair. So here we have our latest BAF, which has been reviewed by the Executive Committee and in December, the Audit Committee. So if I take the Audit Committee first, we had a healthy debate, conversation, and we had an actual offer to further develop our BAF as a board from our auditors. And we've taken them up on our offer, and we have work in progress, but I'm pleased to say that we've been able to identify a date for our board development, which is something like the 18th of April. So that's just something that we agreed last night, and further information will follow. But I think it will be a healthy conversation that they help us with in terms of our current BAF. Is it right? Do we need to do anything different? And what's the learning from other systems? So I'm really looking forward to that. In terms of the current risks, we have a question raised by Steve Clark on 5 of our particular risks. And I'll go through each one and then perhaps invite the relevant director to comment. But the first was around risk number 8, NSFT. And we obviously note from the BAF that the CQC have recently been in. So may I invite Lisa shortly to update if there is anything further to the risk that we've identified, anything further to add since their visit. And then in terms of risk number 9, in terms of NSFT performance, again, is there a further update in terms of their performance? In terms of risk 11, and this is the cyber risk, Andrew, we note that there was failure to recruit recently a program director in security and standards. So given we haven't recruited, does that have a detrimental impact on that risk? In terms of risk 16 relating to the ambulance service, is there any further update in terms of performance that we want to update on? And finally, risk 25 pertaining to our financial risk, is a further update, Howard, that you would wish to offer? So they were the key questions that I think we should be focusing on the back of Steve Clark's helpful challenge to us. And I think apart from that, Chair, they were the key points I wanted to mention this morning.
Okay.
Thank you.
So are there any immediate responses, Lisa and Howard and Richard, or is this feedback after the meeting? Over to you. And Andrew. Yeah, go on, you start, Lisa.
Yes, certainly. So risk 8, which I think is the question. So it's probably not named right, if I'm honest with you, NSFT CQC, because this is about patient safety, not just about the CQC. But we do know that that NSFT are considering their draft report. So I think once we've got that final report, we'll want to update that risk with wider intelligence, not just the CQC. Thank you.
Andrew?
Yeah, thank you. With reference to risk 11, Steve's correct. The failure to recruit to a director of cybersecurity and standards does prevent us from reducing that risk lower at the moment. But we do have a member of staff as part of the digital and data technology team working on cybersecurity, making sure that we're as shored up as we can be at the moment. And he's working with system partners in both SNF and West Suffolk Foundation Trust on linking up our cybersecurity across the system to be as good as we can be. So I'm not confident that, I'm not concerned that we are running into problems, but we can't get the risk any lower without investing some more senior director support in it.
Okay, thank you. And Richard?
Just in terms of response on risk 9, so the pack includes the performance for NSFT and EPUT. There are some areas that are doing really well, particularly IAPT, and particularly where we are one of the best in region. There are areas where we're struggling, particularly around demand, sheer demand, particularly on younger people's services, which is not unique to us. We'll be bringing a paper to the March board around the potential launch of our mental health collaborative within Suffolk, and an update on some of the work we're doing in Essex. So that will touch on some of the performance challenges.
Thanks, Richard. And then Howard.
Yeah, I mean, I won't repeat what we've just talked about in terms of risk going to next year, but there was a conscious effort not to update the finance risk for this particular board, despite the lower risk for this year and the higher risk for next year. I've no doubt by the time we get to March, we'll update appropriately based on what we know at that point, predominantly pertaining to next year. And as Edward has said, one of the actions has already been concluded on there in terms of setting up the finance committee. So.
Okay, so as a board, unless there are any other comments, questions or points, or indeed challenges. Oh, go on, Steve.
Just really to reflect the discussion at the audit committee, which was, we're very happy with this version of the board assurance framework and the discussion that's happened with the exec. Equally very pleased that the commitment has been made to kind of review it. And what the auditors said was that we've got a large number of quite tactical and quite operational risks. And the other ICBs they're working with have a smaller number of more strategic risks, and also are thinking about that issue we've talked about, which is when partners are being managed largely by the national teams, or the risks are being managed through some external process, how we also reflect that in it as well. So just to say there was strong support for this in the committee.
Thank you, Steve, and noted. And also the points you're making play into the development session that Amanda forecast for, did you say April, Amanda, I think, didn't you? So with those comments, are we able to accept the BAF as presented today? noting that actually all the risks are dynamic, aren't they? But a number, as we've discussed, are specifically dynamic for specific reasons, and that we do have the BAF development session coming up, at which we'll review the strategy versus operations, for example, and all risks. And we look forward to the next update, as ever, on this item in the March board. Agreed? Good, thank you very much. Can I stick with you, Amanda, for the ICB constitution? I think this is our first annual review, if I'm not mistaken.
It is indeed. Thank you, Chair. So last July, we signed off the constitution as a board. And at that time, we committed to have an annual review, which I think is a good thing. That time is nearly upon us. So the constitution has been circulated to board members, inviting basically us to reflect on the last year. Is it right? Is it delivering what we set out to achieve? Have we got the membership right? Have we got opportunity to further improve? So a number of questions that I would pose to us as a collective. And may I also suggest, Chair, that perhaps we further consider those questions and maybe in the next couple of weeks, feedback, any comments colleagues may have, so that I can produce an updated version, if indeed that is the case, at our next board meeting.
Thank you, Amanda. So Amanda's proposal is that we take more time than the 5 minutes that we have potentially today to do that review and reflect, at leisure isn't quite the right word, is it? But reflect more reflectively over the next, did you say 2 weeks, Amanda? So responses, comments, thoughts, points, changes, updates, improvements back to Amanda by 2 weeks today. And then you'll incorporate those into a next version, a track change version, which will come to the next board meeting.
Indeed, absolutely, spot on.
Okay, is everybody content with that mechanism? Great, thank you very much. Item 20, the Health Inequalities and Prevention Committee. Over to you, Ed.
Yeah, so we're just looking for support for establishing this committee. I think Richard and Susanna and Lucy Whiteman, who's Director of Public Health in Essex, and Stuart Keeble, Director of Public Health in Suffolk, come together to look at establishing this committee, just so that we have somewhere in our governance that takes an overview of all the work that happens around health inequalities. Obviously, a lot of the actual work happens at an alliance level, at a very neighbourhood level, but we don't have currently any governance that takes a stock of the whole. And that's also important because sometimes there'll be funding that comes down nationally to a system, and we need some governance to look at how it's correctly allocated and supporting the initiatives we have. So I think that's the rationale for it. There's a suggested membership, which of course, we can review going forward, but we're just keen to get something in place. There is an equivalent committee, I think, in Mid and South Essex that's worked well for a period of time, and that Lucy Whiteman chairs, so Lucy can bring that learning into SNE to support us. I don't know, Richard or Susanna, whether there's anything you want to add.
And of course, it does align with the EPSC of the Integrated Care Partnership. So Nick and then Kirsten.
Ed, just a process question. Will you be looking for nominations from the various membership there? And who do we nominate?
I'm happy. I'll follow up, subject to the approval today. I'll follow up partners.
Thanks.
Okay, thank you. And Kirsten?
Thanks, Chair. This is great. I'm really happy that the voluntary sector are part of it. I've got a cheeky ask, really. I wonder if there could be more voluntary sector representatives on this committee. I'm just reflecting back on when we set up a long time ago the mental health work, the transformation programme. There were quite a lot of voices around the table from the voluntary sector, and I think it really helped to change the conversation. And if we're looking for thinking differently, that's kind of the way to do it. Prevention is very much key to what the voluntary sector do in its widest sense, not the sort of very focused public health prevention, but it would be great if the committee could look at prevention in its widest sense, and in that respect have a few more voices around.
Of course, it's one at the moment, isn't it?
Yeah.
Do you, Ed, any thoughts?
Yeah, supportive. I mean, there's a kind of practicality of not creating a group that's too big, but yes, the principle would support.
Would we be, don't want to put words in your mouth, Kirsten, Ed, would we be suggesting as a board to increase that to 2? Would that Yes, 100% increase. Are you happy with that? Yeah.
I'm happy to pick up offline, just rather than try, Chair, if that's okay, just to work it through. The other thing which you'll spotted in the paper is 2.2, the ICP, Equality Prevention Committee, which will have a much broader membership. So I think between Susanna and I, Kirsten, we can talk about how the interface works, because I would imagine, not putting words in Susanna's mouth, but there will be an opportunity for even more wider VCSE engagement through that committee.
Yeah, just following from Richard's comment. So the ICB have already approved the subcommittee, and the reason for the two is so that the ICP really delivers on that commitment around engaging kind of, very broadly, lived experience, voice, across, and also recognising the fact that when we're talking about inequalities, we're talking about so many different perspectives around. So we want to take quite an inclusive approach to how we set the agenda for that ICP subcommittee, how we build on some of the learning particularly from the last few years about not just what we've got right, but also what we've got wrong. I think building on that, absolutely, I think you're completely right that bringing the voice from voluntary community sector into the room really does help us to focus on why before we start talking about what.
Okay, thank you. And Lisa.
Thank you. Sorry to add to your membership, but I'm just thinking, obviously, you'll know about maternity. We're part of the core 20+5. We've got a massive equity plan, and I think we'll need to be represented in some way in this group. Otherwise, we'll be working over here.
Okay, good point. And I saw people, nodding sympathetically to that.
Yeah, I think we'll just need to make sure we balance the membership then. So, because we've also got the other +4 as well as maternity. So let's talk offline, but we just need to make sure the committee doesn't become 50, 60 people and then becomes unmanageable. Equally, take your point.
How about this then? Shall we say that the board supports the establishment of the committee, notes the cases made for increased membership, but asks the executive team to review what is the right way forward with that membership, and comes back to for a nod and a final approval over the membership at the next board meeting in March. Is that okay, Richard?
As long as it's okay if we crack on and maybe set the first meeting up, just require you to get going.
But you carry on, yeah.
Okay,
and then, apologies if I missed it, when would the next review of this committee be? Because there's usually a schedule. Is there a 6-month or a 12-month review? 6 months. Everybody happy with that review in 6 months? Sorry, Susanna, yeah.
So just a suggestion, which is that I think it's important to look at the two together, because there are some assumptions built in there about the fact that the ICP will do some of that broader engagement. And some of the learning we had during the pandemic was that we needed to get better at working with grassroots organisations and organisations able to help us to engage in the right way, particular groups. The other suggestion I was going to make was that, Kirsten, that perhaps we have a specific conversation with voluntary community sector leaders about kind of, how we're advancing both of these different things and ask them how we can get the balance right, because equally, we don't want to bring people onto kind of committees and so on and use their time unless that really adds value in the right way.
Yeah, noted, agreed, all done? Good, thank you very much. Okay, Ed, are you happy with that?
Yeah.
Great, in which case item 21, the policy endorsement, 4 policies there, Amanda. Is there any chance we could go straight for questions? Are you?
Indeed, thank you.
Yeah, straight for questions. Did you put your hand up
Yes,
there?
I did. This will surprise colleagues. I haven't had the chance to read absolutely every line of every policy here. But one thing that I think is really important is that we align as much as possible. So my question really, Amanda, is this, whether it's grievance, particularly change management, have we looked for alignment across? And this is, apologies to colleagues, quite an NHS issue rather than a wider issue. I think we should have as much consistency as possible between certainly the NHS providers.
I completely agree. So 2 comments. So these are legacy policies, but going forward, we do need to get much better aligned as a system in terms of where we can have one policy across the system. So I completely agree with what you're saying, Nick, and I will take that as an action to ensure that we can do that at pace when appropriate.
Yeah. And Amanda, would that go through People Committee perhaps?
Yes, it would.
Okay.
I mean, yeah, what I didn't say is these 4 policies have gone through the Remuneration Committee,
Yes, they
which is the
have.
correct route.
Yeah.
But I think in terms of the wider conversation around policy alignment, it would be the People Committee.
People Committee.
Yes.
So, Nick, do say if you don't agree with this, but can we approve them today, noting that they could benefit from further review, which we asked People Committee to do, and if there are further alignment changes, then they come back to board.
Yeah, no, I think that's fine, but I'm just looking at the change management policy. Clearly, what we don't want to be doing is to take anybody who doesn't want to go down the redundancy route, and given the size and scale of the ICB. And if we line that up, then, between the two key providers, there may be opportunities or mental health, wherever else. And
Completely agree,
we need to
Nick.
approach our workforce in a much more system space rather than organisational space. Support them in that.
So with those comments, approved. Everybody content? Approved. Thank you very much. Now, the next item, committee minutes and highlights report. Now, you might recall at the last board meeting, you asked for, we took these as received and for information, but there were requests afterwards that if people did have one sentence, one point in their highlight to make, that they be given the opportunity. So let's see if we can do that in the 8 minutes remaining. So item A, Audit Committee. Howard, is there anything that you would like to add?
No.
No? Any questions on that report? No. Remcom, Remuneration and HR. Tanya, anything to add? No. Nothing? Any questions? No. And then quality, Steve and/or Andrew?
Yeah, I guess I committed to members of the last meeting, which you haven't got the minutes of, but there was a real sense of the moral injury that staff are experiencing as patients are having heart attacks in ambulances while waiting to get into hospitals, or just dealing with the extreme pressures of work at the moment. And from that, it was an unusual meeting in that the senior executives there were clearly asking for help. And I think the question was asked, what more, the words that someone used, and it's not for discussion now, I think, but the words that were used were, isn't this what the ICB was set up to help us with? And I was just very struck by that. And, others may look differently, but I think there was a real request for help beyond what their employers and providers can do. And I know we heard earlier a lot of the help and a lot of the updates that was given by Ed, but I just committed to pass that message on.
Okay. Message passed and received and noted. Any questions? Finance, Edward, did you want to add anything to your earlier comments? No? Any questions? No? Any questions for Edward? No. There's nothing on people and communities. Estates, Amanda, anything you wanted to note?
Only to note that we are one of 10 systems that are currently working on an estate infrastructure pilot, which is going to conclude at the end of March.
Okay, any questions on estates? No. And then strategic digital investment and assurance. Andrew, anything you'd like to say?
Nothing to add. No.
Nothing to add. Any questions? No. Good. Thanks very much, everybody. In which case, received and noted. Attendance log, again, I think we're just receiving that and noting it, unless there are any questions. Done. Any other business? Non-notified prior. And is this any other a question from the members of the public, or is it any other business? Go on. You may. Yeah.
My name's Mark Marks. I'm here on behalf of Health Scrutiny. And on Wednesday, we are deep diving into the clinical strategy for the ambulance service, which I feel to some extent is a little bit sad, because it does feel very much that they've become the fall guy for the failures in other parts of the system, and their staff, that's being reflected when we meet their staff, and they're very unhappy about the criticism they get from the public, which feels very bad. The question, please, Ed answered part of this early on. Are you giving them any more money? And I think you said there's 200 million coming down from central government across nationally. How much is the East going to get of that? Is it ring-fenced? How is that effectively going to be used? And if I may add to that, I think, we've been discussing over the last 15 years or 20 years that really the position that's really failing is in the community. People don't get prevention, they don't get support because there is not the community support there. And you've put in a couple of systems, the community catalysts, but we're not hearing about them. We've heard that this great system put in by the county council, but we're not hearing about it in the West, and that will help prevent admissions. Equally, you can't send people back out of hospital because you don't have people at home to care for them. So, the ambulance service is taking quite a hit because the other parts of the service simply haven't got the capacity to pick up the workload. And if you look at their clinical strategy, it begins by saying people are coming to us to the ambulance service because they can't access other services. Then further on in their strategy, they say, we're actually not going to treat people who should be being treated by other parts of the service. Well, that's a bit of who's going to pick up those patients then? Because somebody has to. So my question for Wednesday, though, is how much money is coming out of that 200 million? And is it ring-fenced, or is there a reason you have a plan for that money, please? And I think Ed mentioned that earlier on.
Sure. So there's actually two lots of 200 million. So there's 200 million for discharge, and we're working through our... So 200 million for discharge. So discharging people from the hospital into into beds in the community, which we're working through how we're going to use our proportion of that, which I think is about, just below 4 million, isn't it? 3.4 million for SNE. And then there's an additional 200 million to create additional capacity for the ambulance service specifically, which we don't yet know from the national team how that will be allocated. The question that we need to resolve on that is that best spent on more paramedics, which may not be available, or is it better spent on some of the admission avoidance schemes that we're now building in the system that would take pressure off the ambulance service, provide a better care for the patient, etc. So we're hoping that we've got more latitude on how we spend our proportion of the 200 million specifically for the ambulance service. The first bit, that's across the country, yeah, not 200 million for SNE, unfortunately, but yeah, it's a government decision, so we're waiting for them to make their mind up.
Let me just ask Howard if you'd like to add anything. Do you want to add anything to that, Howard?
No, there's nothing to add. We're just still waiting for notification of the allocation and also guidance.
Enough to let us know
Indeed. And one more.
Good afternoon, and Happy New Year to all of you. Hopefully it'll be a little less traumatic than the one we've just been through. The last time I was here in St. Edmund's Room was a long time ago, and the board in front of me then was the NHS Suffolk Trust, and I was here with Peter Meller, Roy Gray and Dr. Feltwell to try to persuade that board that the need in Felixstowe to replace central surgery with a brand new surgery and move the position that the surgery was deemed to be in your long list of demands. And at that meeting, we ended up being successful because shortly thereafter, we started to have the Grove Medical Centre in Felixstowe being built, which was appropriate to current needs. The first time I met this committee was down in Colchester, I think in November, and I asked you then, why was it that the NHS was not supporting the expansion of the Grove to be able to meet the needs of a growing population that was actually being accelerated by the fact that we have a huge amount of development going on in Felixstowe. Potentially over 25 years, an additional 4,000 dwellings, of which it would appear probably 2,000 will be built out in the next year to a year and a half. Now, I have met with the director of Ipswich and East Suffolk Alliance, and she did give a report, and unfortunately she's had to go off to another meeting. But I've recently come into possession of documentation which was presented at a planning meeting back in June of 2020 that showed the capacity of our surgeries with the closure of Walton surgery was 3,519. That is currently being exceeded by a population demand of 34,340, which is actually an overload of 113%. Looking at the amount of build-out that we currently have underway, that is 7 major schemes between 200 to 400 dwellings, plus another 4 coming down the track, which will be completed in the next year to a year and a half, we will probably end up with an overload on our GPs and our surgeries of about 126, 130%. I'm finding astounding that this committee or the NHS itself is not supporting a scheme that is actually supported by the councils, in that the still payments made by the developers, 7 already, more to come, that you're not supporting the expansion of the Grove and probably Haven Health to meet the need of the existing population as well as the growing one.
And your question, sir, is?
The question is, I'm still not clear why it is that the NHS is not availing itself of money that's not a part of its budget, but would actually improve the care provided in primary care, which is desperately needed.
Okay, thank you. Ed, any immediate reflections on that?
Well, there's quite a few reflections, I guess. But so Maddie's gone to Felixstowe, as we just know. We're launching a review of demand and capacity in Felixstowe and the surrounding areas from today, which will be a piece of work that I think is due to conclude at the end of June to report, which will cover all of the issues you've described around housing growth and capacity in the local health service. So I think we'll have a much clearer view at the end of that. But the challenge in Felixstowe, as Peter said, is the kind of challenge all across SNE. We've got huge growth in, Peter mentioned Haverhill and Bury. We could talk about Colchester being the fastest growing community in the country. You know, we've got a big challenge around our resources to meet the growing demand. So there's a specific piece of work on Felixstowe, and we will absolutely involve you in that, Mr. Nimney. But the challenge, I guess, for the board is how we're going to respond to this in many communities across SNE.
Yeah.
I agree with your answers to a degree, but what I find worrying is the community infrastructure levy, which is specifically put upon the developer to ensure that the services are going to be there for the residents they're bringing to a community. They aren't going to actually make the services to the existing community worse than it would be. We're not using the money that is already available to us to use. So I find that very disturbing.
So I agree. We shouldn't miss that opportunity, and I don't know what the blocker is to that. I'll find out.
So we'll find out and report to a future board. Okay, thank you very much. Any other business? None noted. Next meeting is 21st of March, but then in closing, Simon, any questions from the public electronically?
Yes, we've got a couple of questions received during the meeting. The first one is, will the ME service work be eligible for full JFP public consultation and possible referral to an independent reconfiguration panel process? And the second question is, can the board please ensure in future that all works towards reconfiguring of services and joint needs assessment work are done with full public patient involvement before works are made public? Those are the two questions.
Okay, thank you. And are we content to deal with this by written answer, which will be appended to the minutes? So the appropriate exec to pick up those issues. Thank you very much. Everybody, thank you very much. 6 minutes over. I'm ever so sorry for being 6 minutes late, but you caught up a long way. Well done. Meeting closed. See you at the next meeting in March. Thank you very much, everybody.